Right. So I think it's slowing down now with people coming in. So so I will start. I will just start with repeating the content warning. So the presentations you're going to see will include references to trauma, neurodiversity, and personal experiences, and some may find it emotionally challenging. Please do take care of yourself throughout. Feel free to pause, step away, seek support in whatever way that feels right for you. So hello, everybody. Really warm welcome to our two-day conference in Neurodiversity and Trauma. I'm Charlotte Valeur. I'm the founder and CEO of the Global Institute of Neurodiversity. This two-day conference has been organized by the ION Research and Professional Development Unit, also called the Neurodiversity Collective, that consisting of University College Dublin, Maynooth University, ADHD Ireland, Neurodiversity Hub Australia, and ION Global. We are honored to have you with us, whether you're joining as a speaker, a participant, professional, lived experience advocate, researcher, or someone still exploring what neurodiversity means in the context of trauma and healing. Over the next 2 days, we'll be hearing from a range of voices. Some are experts in their fields, others are experts in their own lives. Together, we'll be reflecting on what happens when systems misunderstand neural minorities and how those experiences can leave deep marks on the body, mind, and sense of self. We ask that everyone in this space treats each other with dignity, sensitivity, and care. These are topics that can be both enlightening and activating. We recognize that some conversations may bring up emotions or memories, and we encourage you to look after yourself throughout. A few quick notes about how the event will run. There'll be no open chat function during the sessions to reduce overwhelm and distraction. We'll have a Q&A function available during presentations for a brief Q&A after each of the presentations. Please feel free to post your questions there throughout, and our moderators will ensure they're passed on to the speakers. Captioning is available, and all sessions are being recorded for those who have requested access later. Thank you again for being here. Let's begin this important work with open minds, grounded presence, and care for one another. I will start by introducing our first speaker, Dr. Shanta Dubé. Apologize if I didn't pronounce your name correctly. And she will be speaking on an evaluation of a training on ACE science and trauma-informed care in the US, K-12 setting, importance of self-reflective practice. Dr. Shanta Dubé is a behavioral and social epidemiologist, that was a long word, with a public healthcare career spanning 30 years. Among others, he served as an early investigator on the landmark CDC Kaiser Adverse Childhood Experiences, ACE study in CDC's National Center for Chronic Disease Prevention and Health Promotion from 1999 to 2007. Her research contribution from the ACE study gained both national and international recognition across various sectors and led to CDC awards for scientific excellence. Currently, she's a professor and director of the Department of Public Health at Wingate University. She is focused on ACE science, resiliency, and trauma-informed training across various sectors, including education, child welfare, juvenile justice, and behavioral health. She has also extended the ACE science and trauma-informed care into the health profession curriculum, among other things. Dr. Dubé received the university's Excellence in Research and Scholarship Award in 2024. And hereby I pass over to you, Shanta.
Thank you very much, Charlotte. I appreciate the very warm welcome, and I'm so grateful to be able to speak today. So let me get my presentation launched. I hope everyone can see this. And again, I want to thank you for the opportunity to present some work I did regarding an evaluation of training on ACEs science, adverse childhood experiences, and trauma-informed care in the US K-12 setting. The focus of my presentation is really for us to come together and really understand the importance of self-reflective practice when and as we start to build trauma-informed settings. And this is very relevant for everybody, but really to understand how we need to engage with this learning and how we can work with adult learners to improve and increase their implicit knowledge in this area. So before I begin, I want to acknowledge that I have no financial interests and that this research was partially supported through my prior academic institute, Georgia State University, with a small grant received from the Center for Excellence in Teaching and Learning. I also want to acknowledge that this presentation draws on two publications, one for which I was the lead author, with which this is the main topic of the presentation, but also my colleagues, Carlo Panlilio and Catherine Kaur, where I will present a framework that describes how we need to think about creating cultures of trauma-informed care within educational settings. I always present Dr. Sandra Bloom's quote. She's a physician and an advocate of the ACEs work here in the US. Her quote is, "Adverse childhood experiences studies are as revolutionary as germ theory was for the 19th century." So the objectives of my study today, by the end of this presentation, I hope that all of you will be able to discuss how research on childhood adversities has led to the need and implementation of trauma-informed care. Describe what we mean by explicit and implicit learning and how it is applied in a trauma-informed care training program, and then explain the principles and strategies of the trauma-informed care framework as outlined by SAMHSA, Substance Abuse Mental Health Services Administration here in the US, and then summarize the importance of using self-reflective practice with adult learners using a contextual framework that Dr. Panlilio and Dr. Kaur and I have published on. So this is actually, I know we're in a webinar format, but I did get permission to share this and to get some input from you about what you think is happening in this picture. So if you don't mind writing a few words on, what you believe this picture is depicting with these two individuals. I think there's a Q&A. Let's see here. I can't see it, but I think there's a Q&A. You can enter your thoughts. And if not, I can go ahead and explain what this picture really is speaking to. So in this picture, there's a rock on this gentleman, and the gentleman's trying to pull the woman up. And you don't see the quotes, but the gentleman is telling the woman, why can't you try harder to lift yourself up? And the woman is saying to the gentleman, why can't you just pull me up? You're a man, you're strong enough. But what neither of them can see with each other is that the woman is faced with this snake that looks like it's about to bite her, and the man has a rock on his back. So there's a lot of assumptions going on in this picture between the two of them in respect to why the other cannot help the other more readily when they cannot see what is happening in the background and therefore don't have the full picture. And so I think this is an important, I really love this because I think it's an important analogy to everything we understand about trauma and the experiences individuals that have neurodivergent, experiences and how we cannot see what's really happening in the lives of others. It's not readily seen. And so with that, I wanted to give a background on the ACEs study for those of you who are not familiar with it. It was conducted between 95 and 97. Again, this is one of the key studies that informs trauma-informed care. The aim of the study was to assess abuse, neglect, and related stressors early in life and assess their impact on adult healthcare utilization and early mortality. The study included over 17,000 health maintenance organization participants seeking wellness-based care. It does have a retrospective and prospective arm. We examined these 10 ACEs, and what we found is that actually ACEs were quite common in this cohort of 17,000 adults. 2/3 reported at least one, and then more than 1 in 5 reported 3 or more ACEs. Since this study, CDC has worked very diligently into expanding how ACEs are defined. And so this was, if you will, the tip of the iceberg. This was the original framing of what adverse childhood experiences were based on Dr. Vincent Folletti's observations, which I'll talk a little bit about in a bit. What we also know in the United States, and I understand this work has actually expanded to the UK, Europe, and other countries, is that ACEs through population-based studies have been found to be very common, where 62% of adults report at least one ACE. So in the US, there have been efforts in surveillance at the state level across our 50 states, and now most all the states at one point or the other have implemented the ACEs, what they call the ACEs module, to understand the burden of ACEs in their adult population. So that translates to actually generalizable estimates to those populations. Very similar to what we saw with the original ACE study in terms of population level estimates. And this is the updated pyramid showing exactly the conceptual framework around how ACEs exposures early in lifespan lead to biological embedding of toxic stress. That toxic stress response actually can impact multiple systems, biological systems, the endocrine system, the immunologic systems, neurobiological development. And this is what we are understanding in terms of the pathophysiology of how we see such strong relationships between ACEs and adult health outcomes decades later in life. We've also seen that ACEs increase the risk of biobehavioral issues as well as early mortality. In adolescence, we see that ACEs increase the risk of early initiation of substance use disorder or of substance uses, which can lead to substance use disorder earlier in the lifespan. And so it's interesting, just to let you know what's happening in the US, is despite the fact that the ACEs study started in a healthcare setting, the acceptance and adoption of ACEs science and trauma-informed care actually started in the education system here in the US. It is slowly being adopted and accepted and adopted in the healthcare system, but by far the sectors that have adopted it is education, child welfare, law enforcement, and the justice system. So in terms of what ACEs has led to, so ACEs studies launched, as I mentioned, in 1995. Many different initiatives in the US came about as a result. For example, the American Academy of Pediatrics published their first policy on addressing toxic stress in the pediatric population. That came out around 2012. And then in 2014, the Substance Abuse Mental Health Services Administration put out their TIP 57, which is the trauma-informed care framework, informed by the ACEs study, as well as the study on the women co-occurring disorders and violence study. And so what's really interesting about this framework, and that I think that has led to CDC, in fact, their adoption of expanding definitions, is that trauma can be very all-encompassing. There are many different types of trauma, and the important thing to remember is that trauma, there is a subjective element to trauma. I mean, there's an objective element to understanding what kinds of events can lead to a traumatic exposure, but also there is a subjective because it has to do with that toxic stress response. So to be trauma informed is really about understanding the toxic stress response and apply that understanding to healing and recovery in whatever setting, in whatever population we are working with. So now I'm going to shift gears because I want to talk about, we keep talking about trauma-informed care training, education. I mean, a lot of the legislation in the US across states who have adopted ACEs science and trauma-informed care focuses on, you know, these sectors, people working in these sectors, education, child welfare, have to be educated on trauma-informed care. And now that I'm a co-chair for trauma-informed educational practices at Wingate University, and even in that effort, you know, we're talking about, okay, all the faculty and staff need to be trauma-informed, you know, trained and educated, but we need to understand the nuances behind knowledge acquisition and the types of knowledge acquisition we need to really change the culture and build a trauma-informed care culture of learning, for example, in educational settings. So there's explicit knowledge. Explicit knowledge or explicit learning is when the learner can actually verbalize what has been learned. So it's more of that, the learner knows that. So health education curriculum contributes to increasing explicit knowledge. We've done a lot over the last 5 decades, 50 years to increase knowledge that smoking is dangerous to health. We've done a lot of campaigning around knowing that vaccinations help prevent infectious diseases. So these are forms of what we know as explicit knowledge. We also now know that ACEs are high. The burden of ACEs is high. The prevalence of ACEs are high across all populations that we have, you know, looked at to date. Then there's implicit knowledge or implicit learning. And this is the type of knowledge we acquire where we're not, it becomes more tacit. It becomes more ingrained in our day-to-day, our behaviors, et cetera. And they aren't readily communicated. The way that we've learned these skills and knowledge cannot readily be communicated. And I'll give you a specific example of myself. I do a lot of cooking. And when I cook, some folks will say, hey, can you give me that recipe? And I'm like, yeah, it's very tacit. Like I don't have a way to explicitly share that knowledge with my friends. And it's kind of frustrating sometimes because I'm like, well, I should have a better handle on how to explain. But because it's become so ingrained in how I carry out my cooking, that is a form of implicit knowledge. So what I would need to do is really sit down and, you know, take apart how I am creating these recipes so I can my explicit knowledge can take hold and I can explain exactly how I'm creating some of these dishes that I'm making. Sounds very simplistic, but behavioral responses may communicate what cannot be communicated verbally. And so that is a hallmark of implicit learning. It's our ability to know how to. So when we think about this in the ACEs and trauma world, individuals who have experienced trauma or ACEs are in survivor mode. So their how-to is, how do I survive? What do I need to do to ameliorate negative emotional responses? And so that's a way to think about implicit knowledge in the framework of ACEs and trauma. I share with you Jack Mesereau's adult learning theory because as we begin to integrate this training amongst adults, and so it really takes a 2-generational or a multi-generational approach. If we're going to prevent ACEs and re-traumatizing children, we need to first work with the adults and help the adults to learn. So Jack Mesereau's transformative learning theory is one that I have, that informs the work that I have done in the trauma-informed training that I do. It integrates constructivist theory. So it's about interpreting and reinterpreting the sense experiences central to making meaning and thus leading to our learning or that implicit learning. It's perspective transformation. There has to be an aha moment or some kind of life crisis that can occur through the learning and accumulation that leads to changes in how we approach a situation. Psychological, of course, self-understanding. Our belief systems do get challenged and potentially revised, leading to behavioral changes. And then behavior change requires that the learner has to self-reflect. I mean, that's a key hallmark of adult learning theory, which leads to metacognitive processes, all of which is very important as we think about how we create a trauma-informed environment for the populations that we are working with or serving. There's also this humanistic curriculum approach, which is a summary of 5 basic principles from Maslow. Everyone knows a hierarchy of needs, and Carl Rogers. Learning should be self-directed. Educational settings should be promote students who want and know how to learn. What that doesn't mean we exclude students who cannot. It just means that we have to understand where students are on the trajectory of learning, because when students aren't at a ready place, we deem that as, oh, they are, defiant. But that may not be the case. And trauma may be an underlying factor that can impede their ability to learn. A form of meaningful evaluation is self-evaluations. It's not just about knowledge, but feelings. So the affective state is very much taken into consideration when we look at a humanistic curricular approach. And students learn best in non-threatening environments. That is also one of the tenets of the humanistic approach. So putting that all together, that is how I came up with the why and how of trauma-informed care. It wasn't just about building in content about ACEs or the strategies or the principles of trauma-informed care. It was about being very mindful around how adults learn, how to really get this to be a 2-generational approach, and thinking about a humanistic approach to curricular development. So the overarching objective is to increase awareness, acceptance, and adoption of the ACEs science and action steps for trauma-informed practices that can promote nurturing, supportive learning environments. There's 2 components. There's the why, provides an overview of the ACEs science, and there's the how. Now, the why really focuses more on the explicit learning, and I'll demonstrate that throughout in a few slides. And the how is really about how do we build that implicit learning in the adults. And I intend to share the findings from the study and the qualitative analyses of the 26 self-reflective writing activities that adults engaged in. So the training outline or content, there's a pre-training everyone takes, there's some reading materials, and then they have to do a pre-workshop self-reflective exercise, which they submit. Everything is through an online platform. Then they receive the in-person why segment that talks about the ACEs science, talks about the pathophysiology, the neurobiology, and then outcomes associated with trauma, behaviors, and other symptoms. The how segment then dives into the trauma-informed care framework, the 4 principles, and stress response. And there is a heavy emphasis on self-care, and I'll talk about that in just a bit. And then there are these post-training self-reflective practice activities, which is the focus of today's talk, where I'll present some findings. So at the beginning of the training, and I maybe should have presented this at the beginning of this talk, but we're not doing this is a webinar format, but in an interactive learning environment, and I present this even in my regular MPH, my Master of Public Health curriculum, that we foster a safe and supportive environment for learning. We always want to use the THINK acronym. Is it true? Is it helpful? Is it inspiring? Is it necessary? Is it kind before we speak or write? No questions are dumb. We maintain confidentiality in whatever is shared, because during the in-person training for the why and how, people do come and share sometimes their personal experiences or experiences with students. We want that kind of dialogue, but we want it to remain confidential. And then incorporate the 3 N's: non-judgment, respect and mutual understanding, non-diagnostic. So we want to understand that trauma-informed care and assessment for trauma is not about diagnosing. It's about having a good understanding of the population we're working with. So it's not a diagnostic tool. And then create nurturing environments to be accountable and aware of how we are contributing to a safe and supportive environment, and potentially recognizing stress in others when we're in the learning environment. So the why training content includes the origins of the ACEs study, including Dr. Vince Folletti's very early observations that led to the ACEs study. His publication was 1993, predates when ACEs study was launched in 95. But that provides an overview of how he observed patients losing weight but dropping out, and then how he brought them in for clinical interviews and learned that they had experienced many types of abuse, but primarily sexual abuse, and how he talks about in those patients, they articulated that the weight was a protective solution for their early life trauma. We then present data on the ACE study documenting the long-term developmental and health impact. We discuss how ACEs lead to developmental neurobiology of stress and trauma. We talk about Bruce Perry's neurosequential model, the thought that all of the trauma is in the brainstem, and how the brainstem is basically on fire, and that prevents any higher order ability to make for decision making, and this leads to why kids are sometimes impulsive, have difficulties regulating emotions. So it's a really good model to present to the participants to understand what's happening. And then we also present the 2-generational 3-level prevention framework, which focuses on the adults working with children. We discuss positive childhood experiences as well, and this is newly added. And this is a very critical area that is now really expanding, because we now know there are PCEs, or positive childhood experiences, that can mitigate the negative outcomes associated with ACEs and can even prevent outcomes associated with ACEs. The why training content then goes over this graphic to show kind of across the lifespan when ACEs occur in childhood, when we can begin seeing the outcomes and what those outcomes look like, typically in adolescence, and how they lead to adult health outcomes. And we talk about the intergenerational cycle, that those adults who reported ACEs and have certain outcomes like substance use disorder, the kids that live in their environment may be also experiencing ACEs. Then we talk about the how, and the training content here reviews the trauma-informed framework, talking about how ACEs informs that. We go over the 4 principles. Now, in the framework that SAMHSA provides, they actually call these the strategies. I kind of flip things. I call these the principles, the 4 principles, and then I flip their their principles to strategies. So there's a little flipping going on. But the 4 principles are realizing trauma is widespread, recognizing symptoms, responding using 6 key strategies, and resisting re-traumatization. And so when we look at this, and I put work settings because this can be in any setting adults interact with children, but we want to understand that all children, including adults, have experienced at least one ACE or one type of trauma. We want to be able to recognize symptoms. This could be anything from somatic pain to behaviors to emotional dysregulation. And this is what the science has shown us. Then we want to respond using 6 key strategies by providing that safety, peer support, collaboration, empowerment, voice choice. And then one of the key areas that my training focuses on is resisting re-traumatization. And what comes in play here is self-care. There is a heavy, heavy, heavy emphasis in the training and the how segment on self-care, because we have to be able to enhance our own resilience to manage our stress so that our triggers, and we go through an activity on understanding what triggers us in the training, so that we are aware when something happens with a student or a child or somebody, even another adult, we are able to recognize how we are being triggered and our stress response. And then this, I think this is the last slide. We also address the stress response in ourselves and others. In our evaluations, most people do not know the stages of stress. I'm giggling, not to be, condescending, but most people think the first stage of the stress response is the increase in our physiologic response, like our heart rate. Actually, the first stage is our sensory input. So what we see, hear, smell, our 5 senses are actually the first stage. And it's because that's how we're perceiving the world. And then quickly our brain decides whether it's a threat or not. And so that's a big aha moment in the training that we provide. And then active learning, again, this has to come, self-reflective practice comes into play here, and I'm going to share with you what we do around self-reflective practice. I want to be mindful of the time. It's 9:35, and I think I have maybe 5 or 10 more minutes. So in the self-reflective practice that they engage in, they are asked to keep a weekly log every Friday and summarize the following aspects of their week. How is a TIC training influence how they think, feel, and act in difficult situations with students? And then reflect on a most difficult situation, and then continue to reflect on positive experience. Is reflecting on positive experience enhance their efforts to create a trauma-informed environment? And then they are asked to provide a reflection of a positive experience. This is the online platform we use to deliver the training. Any learning management system online, Canvas, I think this one was D2L, I think. We changed a couple while at Georgia State. The current learning management system we use at Canvas, at Wingate, is Canvas. So that platform can be used as well. So what I'm going to present, there were 27 teachers, counselors, and paraprofessionals, and this network was called Educational and Therapeutic Network for students who had either learning or behavioral difficulties or had a diagnosed learning challenge. And so they were a very specific select group of paraprofessionals, counselors, and teachers. These were qualitative analyses. We ended up looking at 26 transcripts, and the coding was based upon themes related to the 4 principles of trauma-informed care. We did do a pilot study and randomly selected 5 transcripts at 3 different time points of when this self-reflective activities were submitted. I'm not presenting that here for time, but that helped to inform the analysis of these 26 transcript. So before we get into some of the data from there, here is what we gathered after we reviewed all of them. We did see this theme of recognition around ACEs, behavioral difficulties, emotional difficulties, symptoms, distress, contextual factors. And so we saw this when we heard respondents identifying some characteristics of the underlying trauma that they saw in kids or knew about in kids. And recognition was readily identified. And they said that the ACEs lecture was referred to, and I mean, they referred to the ACEs lecture as a way to understand what they were seeing in the kids. This learning connection, so this is in reference to elements of all principles of TIC in their process of understanding the day-to-day challenges that they experienced. Response, this was this whole strategy of transparency, honesty, voice. And so what we saw in the transcripts was creating or building trust and creating safe environments by engaging in behaviors that promoted respect for students and voice. So I will share with you some of the quotes that they provided that demonstrate this. And then acute action. So I had another educator actually help to analyze. And so an acute action in an educational setting is an immediate response action needed to make sure physical safety is assured and their role responsibility is met. So that we also saw, and that had to do with de-escalation, utilizing required protocols and adhering to responsible practices. We also saw collaboration, and so this was depicted in not acting alone, communicating with relevant professionals, preventing and trying to stabilize and prevent re-traumatization. Safety was a big theme we saw. We saw this demonstrated through action or intention to create either emotional or physical safety. And then by promoting self-awareness, they became, the teachers and the adults themselves demonstrated their own acuity to, being able to engage in self-care in the moment, utilizing evidence-based practices to promote self-regulation and emotional regulation in themselves and actually in children. So I want to get to the quotes, and I'm only presenting some of them. These are in the publication. So I want to highlight this transcript. One of our students became highly upset, emitting high piercing screams. And so I underlined what the adult teacher engaged in. I moved a small distance away and spoke quietly, intermittently. She was able to stop screaming and shouting and moved to a desk and began classwork. So some of the labels we find is recognition, response, providing safety, resisting re-traumatization, and observation of how the practices led to the students coming back to equilibrium. In transcript 2, this one said, I observed self-harm behaviors in the children I work with. When I observe these behaviors, my thoughts were in the child, is the child all right physically, and what caused a child to harm themselves? So kind of that recognition, what might be the underlying influences towards this. But underlined, I want to just emphasize immediately conference with the child and made sure the child received attention from the school nurse and then contacted child's parents. So that's that action, that acute action that has to take place in certain situations, and then collaboration and creating safety. Then another talked about being at an IEP meeting, which is, this is IEP meetings, for those of you who don't know, are created in the public school system for students who need to meet certain benchmarks and have specific educational plans because of certain diagnosed disorders or learning difficulties. So I was flabbergasted in an IEP meeting. A parent was very rude, rolling her eyes. So instead of reacting, this individual said, I stayed calm and closed my eyes for about 15 seconds. once I open, I found a picture to focus on. So really that recognition of their own potential triggers, being self-aware and engaging in self-care at that moment. And then these are just other examples of where safety was carried out. So this is a student, I spoke to a student in a calm voice, trying to prevent him from escalating any further. And then this was a way to engage the student also to try to discuss the problem. And then this last one, a situation where there was a sexually inappropriate comment. So recognizing how the person responded to that, they had self-recognition, but then walking away and then being able to kind of really reflect and in their way prayed that things would actually be okay. So some other things to keep in mind that you won't see in the data in the publication or in this presentation is not all individuals are at a ready point for self-reflection. Not all individuals conveyed an aha moment, but several of the participants did have a perspective transformation regarding their own health and started really engaging in self-care to promote their health. These findings are not generalizable. It's qualitative data. It did not include a control group. And the self-reflections are indicator of trainee understanding, but they don't provide any data on the level of behavioral change. So this is the conceptual framework that these findings will lead to. To date, we have focused on early adversity and academic outcomes, but we have this need to really focus on self-regulation and self-regulated learning through really building that self-reflective practice. And so we want to promote trauma-informed ecosystems, and trainings such as this with experiential exercises and reflective practice and learning can help us. Understanding how individuals process the learning and engage and apply the learning through self-reflective practice is critical for us to really promote trauma-informed care. And so future directions continue to evaluate similar data from other trainings, maybe really finalize on key indicators for trauma-informed care, and then continue to work in this realm to promote this training. So I'll stop. I know I'm over time, so I apologize.
No need to apologize. Thank you so much for this really, really interesting piece. There's a lot of sort of coming out to me being autistic and having ADHD myself. Interesting with the third stage that the sensory piece was where it was first detected, and many of us have a really broad sort of sensory band, so we certainly feel that very intensive. We have one question here for you. The training sounds incredibly interesting, and someone is asking, do you train coaches? And is the training described more or less what you do?
I'm sorry. And the first question, do I train coaches? Yes, I do train coaches.
Is the training described more or less what you do?
Yes, this is the training. I will say the added component will be a little bit more on positive childhood experiences because there's been a lot of research. I will say the original training was heavily focused on the pathophysiology, but I use the term solutophysiology in my updated training to really focus on what can we do to promote resiliency and promote our positive physiology.
Fantastic. And another question here is, how do you gain access to the training? People are clearly interested here.
Well, I guess it would be through talking with me, and because this is a training that I had actually developed as part of as part of a project that I worked on, and I'm continuing to deliver it to health professions, but not. I don't deliver the whole training program right now to health professions, but I hope to. So I'm happy to leave my contact information. Is that okay?
Yeah, that would be fine. Or can people reach out to you on LinkedIn or somewhere else? Or
Absolutely. Yes. Would you like me to share that link?
You can also share your contact information and email if you wish in the Q&A.
Okay, let me do that.
The best place to put it. So
How do I put it in the, it just, okay, sorry.
I have no clue. I'm so sorry.
It's okay. No, I found it.
Excellent. So the next question is, under the current administration in the US, will the training regarding the ACEs be as widely taught, or have you seen a decline?
That's an excellent question. Right now, what I can tell you is at the state level, this work is moving forward. So I'm in the state of North Carolina, and I will tell you the Attorney General signed a letter saying that they want all court systems to be trauma informed. So while at the federal level, there might be some challenges, the states and the local entities still have some ability to do some grassroots efforts. So I'm currently actually a lead evaluator for the Union County Opioid Settlement Project. And in that respect, the funded partners are utilizing ACEs science and trauma-informed care in their work. So I think that it's a great question. I think that because the science is already out there and states are adopting this, that we will be moving forward.
Okay, this is a perfect segue into our next speaker. So we will see Shanta again at the end of the day for the panel, where you can also ask more questions should you have anything we didn't get to answer. Thank you so much for being here, Shanta. Thank you. So the next, hello, Becky. And I think I saw, did I see Helen as well? I'm not sure. But the next one is Dr. Helen Gowling and Dr. Becky Hull. There you are. Hello, Becky. And the title is Being Neurodivergent in a Neurotypical World, The Road to Trauma. Dr. Becky Hull is co-founder of the Divergent Space and a clinical psychologist. Becky brings over 20 years of experience working with neurodivergent adults. Passionate about co-creating inclusive services, she has developed NHS diagnostic services in the UK and specializes in autism assessment and therapy. Becky's mission is to build a service that aligns with what people need based on her own lived and professional experience. Dr. Helen Gowling, co-founder of the Divergent Space and a clinical psychologist, Helen is passionate about using a neuroaffirmative approach to support neurodivergent individuals. As a neurodivergent professional herself, she believes in celebrating strengths while acknowledging challenges. Helen has worked in the NHS in the UK since 2014 and specializes in autism diagnosis, therapy, and service improvement. Thank you so much, those of you, for being here. Delighted to have you here. I will pass over to you and take myself off screen. So all yours.
Okay, right, I'll just see if I can share this presentation then. Just give me a second.
And just for clarity, because it says Becky Hull under both our names, I'm Becky.
I'm Helen.
Yeah.
There we go. Is that able to be seen? Can anyone confirm?
Yeah, I can see that.
Yeah. Okay. Thank you. Brilliant.
Okay. So thank you, and thank you for that introduction. As I say, I'm Becky Hull. I'm a clinical psychologist and one of the founders of the Divergent Space, which is a service set up in North Yorkshire in the UK. But we see people from across the entirety of the British Isles. Either people have travelled to our service to be seen in person, or we also do offer online support. Yeah, Helen?
Yeah. No, I just want to say thank you very much for having us here to speak today. I feel like this is a really important topic that needs to be discussed more, so it's lovely that this is on with some great speakers today. I think I'm really excited to kind of share this information with you all, both from my own experience with my own differences and challenges, but also having a partner who's neurodivergent and my children as well. So yeah, thank you very much for having us. Should we start on the presentation? So I just wanted to begin just to kind of give a little bit of background to the language that we are using. So for some people, this will be really familiar, and other people it might be new. So just try and approach it with kind of that beginner's mind and the curiosity. So around the founding terminology, neurodiversity refers to variation in brain function. So these terms, it's important to note, aren't clinical or diagnostic. They've been developed within the neurodivergent community over many years. I can't remember kind of when the terms first came out, but the movement came out as a result of wanting to promote the idea that there are many different kind of brain functions within the population, and that's part of normal distribution. And not that these differences don't come with difficulties or challenges, but it is just part of human diversity. So the neurodiversity movement implies that there are these variations, and some of these are what we may call neurotypical. For lack of a better term or definition, I would describe someone who is neurotypical as someone whose executive functioning or the way they experience their sensory world is considered the norm within a given population. So there will be individual differences within this, and there may be kind of different parameters depending on kind of culture and background. But basically, there's a sort of a benchmark, a societal standard of what's kind of considered the majority. Neurodivergent would be people whose functioning in those different areas differs from what might be considered the norm. And these terms aren't intended to have any judgment or be critical in any way. It's more about helping recognise that there can be these differences. And then within these differences, that's what makes up what we call neurodiversity. So a person is not neurodiverse, the population is diverse. An individual would either kind of fall under neurotypical or neurodivergent, depending on where they happen to fall within that diversity. And then we've got that term neuroaffirmative. So this is very much a way of working that aims to move away from kind of that deficit model of neurodevelopmental conditions and away from the pathologizing language that often gets used. So there is much more focus on strengths, but a lot of the focus tends to be there's differences, and that doesn't mean better or worse, but with a real strong recognition that with these differences, there can be significant challenges as well. And because we are touching on kind of trauma today, I did just kind of want to say kind of what we're meaning by that. So trauma, the way we think about it today, is when we experience very stressful, frightening or distressing events that we feel unable to cope with. And that might be a combination of our own internal processing systems and lack of kind of outward support around us. It's a subjective experience that can't accurately be measured. And how an event is processed rather than the event itself is what's really important here.
So having worked in the field of neurodivergence and autism for over 20 years, I've seen that rapid change in the way that we understand the autistic experience, and also in the UK, in the divides between where the line is for what constitutes a diagnostic and a disability and what is getting capturing just a different way of being in the world and how we navigate that. And I supervise a lot of other psychologists who really wrestle with that idea of the impairment and where does the impairment lie. I've also spent most of my career working in complex adult mental health. So where we're meeting people where the consequence of their experiences are actually having a real detrimental impact on their functioning and on their day-to-day well-being, and that they haven't been able to access those traditional ways of being able to work through the therapeutic process and work through their own recovery, because in very subtle, nuanced ways, those services are inaccessible. Okay. The reason we wanted to talk about this is thinking about some of those nuanced ways, some of those issues, because I think this quote sums it up really. Being in the minority in a neurotypically biased world, and where your differences are perceived as deficits, is not a good starting point for anybody coming into a session. So repeatedly, increasingly, the literature indicates that an autistic or a neurodivergent person, we tend to use the phrase neurodivergence in our service because it encapsulates that broader difference in the way the brain works, and it recognises that autistic individuals are likely to have more than one difference in terms of a neurodevelopmental condition. So it's widely accepted that neurodivergent individuals are more likely to present to a mental health service. But often that's the end of the curiosity. It's why is that? So as an example, in their study, Gertz and Janssen showed that almost all of the autistic adults in their study were known to the mental health systems before they received a specific assessment for autism. So a lot of the adults that we will see are already flying under the radar. There's an assumption about their neurotype, and often they will have engaged in therapeutic processes and failed in therapy before they get there. Okay. The median in Gertz and Janssen's study for the time elapsing between the first contact with services and autism being considered was 12 years. And the longest somebody was known to mental health services was 56 years before their autism was considered. So that's a huge amount of time where individuals are trying to access that support. Their trauma is recognised, their mental health challenge is recognised, but their neurotype is not. And what we wanted to do today is to spend some time just thinking about, if we accept some of these research that's saying that being neurodivergent increases your risk of a comorbid mental health challenge, we want to think in real lived experience terms what mechanisms might be underpinning this. Okay. And just as an aside, I want to acknowledge that we do acknowledge the world has people within it that seek to cause harm to other people. We're not here today to dismiss the responsibility of those that cause the harm to our autistic or anybody else. But we want to think about, why does somebody experience a trauma reaction when there might be no clear observable trauma? And so what we're going to use, because we're psychologists, is our lovely biopsychosocial model in thinking about people.
We're kind of starting on the bio bit of the biopsychosocial. I'm going to mention a little bit why some differences in our nervous systems may lead us more vulnerable to processing adverse events and experiences as trauma. So as a caveat, I'm not a neuropsychologist. So there may be people here who understand the neuroscience behind this far better than I do. This is kind of based on the research that I've done into this area. So there is research that suggests that autistic brains have additional neuronal pathways termed hyperconnectivity that are diffused throughout the brain. And this can come with strengths, but it can also come with challenges as well. There can also be differences in the way that the two hemispheres communicate with each other by the corpus callosum. So why does this matter? I want you to try and imagine that corpus callosum, which is really easy to say, as a highway. So a 4-lane highway at a quiet time of the day, so not a lot of traffic on it, everything is moving really freely. That is generally how it's supposed to work, where information processes quite easily. However, for a lot of people who are autistic, the highway is more like 3 lanes are shut due to roadworks and it's rush hour. So the information is still getting through, but the processing can be a lot slower. So in addition, that kind of hyperconnectivity in certain areas can cause us to kind of go around and round and loop the information, which means that combination of those two means there can be a delay if we have an adverse experience in processing it and bringing in the logic and reasoning and wider contextual factors. As well as these potential brain differences, neurodivergent people tend to have what we call kind of like a small window of tolerance or a more rigid nervous system. So it's easier to kind of flip into hyper or hypoarousal. And it also takes us longer to get back into our window of tolerance if we have gone into that stress state. So because of that, we can have a heightened stress response. And that means we tend to experience more cortisol, adrenaline, and activation of the stress response throughout our lifetime. So we've got situations where we might be processing experiences in a different way. We might go into our stress response a lot more easily. And we know that how we communicate those internal experiences to others very much correlates with how likely it is that we will have those experiences validated.
Okay. So thinking in terms of sensory processing, and as we were aware, the sensory processing has only been included in the diagnostic criteria for autism since the DSM-5's release in 2013. And it's been associated, though, with autism since the very earliest writings on the condition. And there has long been debate as to whether sensory processing differences exist, coexist, or should be considered as a core component of autism at all. But as we stand in 2025, both diagnostic manuals indicate sensory processing differences. It's not currently in the diagnostic criteria for other forms of neurodivergence. But again, there are many who think that it's of significant importance that we understand sensory processing. It's a personal bugbear of mine that we're not all trained in sensory processing as part of core training. Most up-to-date research was showing that 90% of autistic individuals have an atypical sensory experience. So they're either going to be more sensitively calibrated to their sensory experience. They're either going to be hypersensitive or have a hyporeactivity. And the most frequent unusual response is to tactile stimulation. If we're in a world, our sensory processing is a very, very unique personal experience. And it's not something that I think we talk about every day. It's very easy for our sensory processing to be seen as irrational or illogical, or that people are making a fuss because the other people that are around us don't notice what's going on. They will think about, it's not that bright in here. Oh, it's not that noisy. What were you expecting? It's fine. It's fine. You'll get used to it. But also on more subtle ways. So within our own internal sensory processing, how we feel, how confident we feel, how safe we feel, how unbalanced we feel, how close we are, So as somebody with dyspraxia, I'm aware that I bump into things all the time, and my childhood was the classic line of how I was clumsy, or I was cack-handed, or don't give Becky that, or she's not capable of doing these tasks, because I had such difficulties in knowing where I was in space, and would often, rather than being seen with somebody coming alongside me to work with me and teach me how to do the skills, it was more written off. And so my confidence gets knocked again and again and again. So we have this situation where individuals, their reactions may appear unusual, But for the individual themselves, they are always logical and proportional. But they can lead to a sense of withdrawal. They can lead to people not putting themselves out into the world, or they can lead to other people judging the behaviour that somebody's having to do in order to be safe. And when these experiences are happening from a very young age, the building blocks of who we are and what we're confident in doing, they slowly get influenced, and our self-esteem and our sense of autonomy and empowerment get knocked. The other area with sensory processing that I always remind people to be mindful of from a psychological perspective is the area of interoception and the theorized links between this and alexithymia. So there isn't a satisfactory scientific explanation as to what an emotion is. We can't encapsulate an emotion as a thing, okay? The best working hypothesis we have is that there is a physiological component, something is happening in our body, and then there is also a cognitive component which it interprets that physiological sensation based on personality, based on context, based on the information the person has at the time. So physiologically, how a child will feel on Christmas morning and how a child will feel before sitting an important exam, they may be very hard to distinguish between on a physiological sense. But on a cognitive sense, the child will make an appraisal that says one is anxiety and one is excitement. Okay. So thinking if we're not an individual who is receiving that physiological sensation at an early enough level, i.e. we only receive the interoceptive messages of what's going on in our body when they are very, very potent, okay, then we're more likely to reach overwhelm without any pre-warning, and we're more likely to have our experience invalidated or have other people telling us how we feel without giving ourselves the time to gather the information. On a very basic level, if I don't know how I'm feeling, how could I possibly tell you? How can I possibly get the support that I need? Okay. And how can I keep myself safe? Because actually, a lot of social interaction relies on that kind of gut sense, on the hairs on the back of your neck or something turning over in your stomach. I've had this experience myself this week. I've had to trade a new car in, and I've met with multiple car salesmen who have all worked out the logical reason why I should buy the car and a logical reason against any fault I can see or any problem I can see with the car. They've worked that out before I've even arrived. And so I'm really been relying on that kind of comfort, the messages in my body telling me, do I think this is a good choice for me or not? Okay. If you're a bottom-up thinker, if you're somebody that is processing and perceiving your world through data gathering and pattern recognition, and less on that physiological, intuitive sense, then the time you need to spend in an environment naturally increases. It means that you are at risk, that you will be exposed to the adverse environment for far longer while you gather the information that tells you whether you're safe or not. And that therefore increases your exposure to people that may seek to manipulate you or harm you or gaslight you as well. Okay. So I think it's always worth thinking about that actually just through the need to data gather and to build up a picture of the world, people may naturally end up being exposed to noxious environments for much longer.
I just wanted to add on to this, kind of like summarising these kind of nervous system differences, that if we've kind of got this detail focused processing bias along with differences in sensory processing, this is very likely to exacerbate the formation of vivid sensory trauma memories. And this increases the risk of those reactions that are often kind of seen as PTSD responses. And it also explains why events that generally might not be considered traumatic can be experienced this way by neurodivergent people. So the research shows us that includes a much higher level of social-based trauma, along with other situations such as the death of a pet and even psychological therapy and the diagnostic assessment itself have been reported to have been experienced as traumatic.
So what happens to us when our system is overwhelmed? When we go out of our window of tolerance and into a situation where our nervous system is triggered, where we're not able to process and regulate, or where the overwhelm is being continued and perpetuated because of the environment that we're in. Typically, what we're learning more about all the time is that an autistic individual is at an increased chance that they will experience a meltdown, which is a phenomenon with varying expressions by which an autistic person feels entirely overwhelmed. We might see, if we're observing a meltdown from the outside, outward anxiety and energy outpour. It might include the person becoming more aggressive, bigger body movements, more clumsy body movements. It might be that they become more vocal, louder, snappier. Their language may change. They may use more swear words. They might scream and shout, and they might end up either harming themselves, harming others, or damaging property. Okay. Some of the factors that contribute to a meltdown are often cited as social demands, frustration, the fact that people feel that they can't communicate correctly, and just not being able to get to a straight edge, if you like, not being able to get to a place where they're not firing on all cylinders. So an alternative to the meltdown may be that the person has a shutdown. So these are triggered by similar events, but the person has more of an internal experience where they may observably seem to withdraw from their surroundings, but it's accompanied by an emotional pain. And the degree to which the person's function changes during a shutdown ranges from mild, so still being able to walk and around and talk, but at a slower pace, being less verbal, being less responsive, to more severe, so feeling detached from your limbs, going into a fetal position, losing speech entirely. Autistic people that experience meltdowns and shutdowns, they will commonly talk about the anxiety that happens for them, or the terror that happens for them during these episodes, in that they are disconnected from their skills. That they are, as one individual said to me, the words are literally smashing against my skull, but they will not come out of my mouth. And there's also a fear because the pathway to the recovery of those skills is not always straightforward and quick. So I have worked with somebody who, when they're coming out of a shutdown, they will whistle, or they will perseverate on the same word over and over, and the frustration of trying to get another word to come back. Or they can't predict when they're going to be less verbal. And then, of course, once we've come out of the shutdown or meltdown, because these are observable behaviours, they've often been perceived by other people incorrectly. So there's that increased chance that the individual, at a moment of extreme emotional pain and distress, they are going to get a social response of judgment, of invalidation, of rejection, that their needs are not going to be seen, that they may well be attract labels such as lazy or obstructive or stubborn if they're in a shutdown and they're not responding, or it may well be that they're seen as naughty or bad or aggressive if they're in a meltdown, or that they're just having a tantrum and then they're infantilized. And I think that a lot of autistic people will talk about that sense of being invalidated in the moment of their shutdown or meltdown because they can't communicate what's wrong. One of my clients, she gave a lovely quote. She talked about her child having a meltdown on the way to school and said, if it took 4 men to carry my screaming 12-year-old into my house at the end of the school day, somebody would ring social services. But apparently, it's okay for 4 grown men to carry my screaming child in meltdown into school with absolutely no question as to what has triggered that meltdown or why he is so afraid of the school environment. And I think that's a really powerful thing, isn't it? That sometimes the responses that we give to people in emotional pain, because that episode of distress is disruptive to other systems and other demands of life, the person gets very invalidated. And they'll often talk about afterwards, yes, feeling that emotional discharge, feeling that their body has almost reset, but cognitively having a lot of worries about shame and embarrassment and fear because of their behaviour.
One of the things that I just wanted to touch on really quickly was kind of skill inconsistency, which we often experience as neurodivergent individuals. So our capacity to do a thing may vary from one day to the next. And that can be due to a number of different factors that we might also be having to deal with. But this is something that is then often used to invalidate and dismiss people's experiences. So, for example, a child going to school might be able to do it independently, put their coat on and zip it up in the morning when they have more resources. It's the start of the day. But by the end of the school day, when they've had to be in an environment, thinking about all the kind of sensory input that they've had, kind of trying to learn, trying to navigate the social environment with that. By the end of the day, they have a lot less capacity to be able to do some of these skills. So they may be unable to do that without support from someone. But often it would be a case of, oh, well, you managed it fine then, why can't you do it now? Like it's something that is a choice, or they're just playing up, or just doing it for attention. That's really invalidating. And things that can further impact on people's ability to manage day to day are the experiences of inertia and burnout. So a qualitative study looking at people's experiences of inertia described it as it's a prolonged mental state of feeling stuck, which results in the physical inability to engage in activities even that you wish to do. It's been described by autistic individuals to vary in severity, duration, and the rate of repetition. However, all agree that it's very debilitating. With burnout, this is generally described as a distinct source of severe and chronic exhaustion. Autistic bloggers have highlighted that the causes of this can be quite uniquely autistic, such as masking, the constant need to exhibit appropriate behaviours to try and fit in, to try and be accepted. And I thought this model was really good that it kind of shows the factors that can lead to burnout. And we know that when someone kind of has reached that stage, recovery can take weeks, months, or even years, just because of the impact that it has on us. But the emotional response to this is, we often experience frustration, shame, stigma, and fear. The response from others is that, if we've managed with something at one point and then not the other, we're unlikely to have accommodations kept in place, or we're not believed, or people will get impatient with us. So it kind of all contributes to that sense of who we are.
So moving on to thinking about the social, how people communicate and interact in the world when they're having these internal experiences that aren't always apparent. So in his 2012 article, Damien Milton coined the phrase the double empathy problem. Okay, so Milton is an autistic self-advocate, and he asked, what if there isn't a single empathy problem, but a double empathy problem? And Milton argued, quite rightly, in my opinion, that if it was easier for autistic people to bridge the empathy gap between one another, the same thing was, and the same thing being true of neurotypical people. So simply put, autistic people tend to have trouble empathizing with neurotypical people more than they do there are people of the same neurotype. And neurotypical people tend to have trouble empathizing with autistic people. The difficulty with empathy does not lie in just one party. The problem is the communication between different neurotypes. Okay. So services are not easy to navigate for autistic people. Okay. We're living in a time when we have never been more encouraged to seek support, to take care of our well-being, to talk about our internal emotional state. But typically autistic ways of looking after ourselves, deep diving into data, asking very specific questions, gathering more information, needing very specific detailed answers. I've sat in a lot of care planning meetings where that way of being and that way of engaging is being seen as oppositional by the staff team that are supposed to support these people. That people have been told that they're being too challenging, or they're arguing, or they're being obstructive. And the person has ended up feeling really rejected, dismissed, misunderstood, when actually what they've been trying to do is exactly what they've been asked to do. They've been trying to engage in the process of recovery and desperately wanting to get it right, and yet somehow still leaving the therapeutic interaction feeling that they've got it wrong. Okay. Or the system not acknowledging the illogical loops, the feedback, the conflictions between them. The parent who's mental health nurse and child school counsellor and their own physical health nurse have all given conflicting demands to the client because the system is too fragmented. And the client is then left not knowing, how am I supposed to prioritise these demands, and becomes stuck in analysis paralysis, and then tries to get more information and gets knocked back further. Okay. So, yeah.
Yeah, I'll say a bit about masking, because I think it's important to recognise that this can be a part of many neurodivergent individuals' experiences. So it's sometimes known as camouflaging, and is generally a strategy used to try and fit in with neurotypical peers, or with how we think others expect us to be, to feel accepted. So it can include behaviours such as copying or mimicking others, constantly monitoring what our face, what our voice, what our hands are doing, so that we kind of look normal. Learning scripts for social situations, and really hiding aspects of our personality or ignoring what our needs are. But when we start from that perspective that we need to really downplay a part of ourselves because we feel that we've already had the messages that we are unacceptable or inappropriate or getting it wrong, then this massively impacts on self-confidence, self-acceptance, and self-worth. And judging ourselves as unacceptable goes way beyond just learning a few social skills. It means that we are just completely disconnected from what we need. We stop listening to and recognizing our own signals for the comfort of other people, to try and limit that being rejected. which this also, I mentioned earlier, plays a lot into that experience of burnout, because it just massively impacts on our levels of exhaustion and our well-being. But the problem is for people that, you know, quite skilled at the masking, when things do get beyond the capacity to kind of cover it, again, we have experience of not being believed, being invalidated. And we also know that from the research that individuals who have this as an effective coping strategy, the risk of going undiagnosed, having their autism not recognised, is much, much higher.
So that's this YouTube link. Sorry, I'm having some verbal fluency difficulties today. This YouTube link is to two British artists, O'Hooley and Tiddo, who are two autistic adults who have produced a song called Cloudheads. And they've given us permission today just to bring your people's attention to it. It's well worth a listen. It's a really powerful song and music video about being in that autistic world and what it's like growing up as an autistic individual and the types of responses people get based on that.
Thanks. Yeah, we're not going to play it now, but it was just to bring your attention to it. Oh, she says, and then it starts playing. So thank you very much for taking the time to hear us chat about this topic. And we're happy to answer any questions.
We do have 5 minutes, 6 minutes in fact. So thank you so much, both of you. That was really great. I enjoyed listening to so much of it. I really were happy that you brought in the double empathy issue, and because it is something I'm discussing with so many people all the time, because we express our empathy differently throughout different neurotypes, and that's just really badly understood. And the whole too sensitive piece, I mean, I think my entire life since I was very young, I've been told I was too sensitive. And my dad kept saying to me I was smell allergic. And I literally am smell allergic, but it's hard to live with when there's a lot of, especially smoke smells. I just couldn't handle it since I was very young. So we have a couple of questions. Let's just go through those, please. So the first one is from Eamon, who says, would things be better if we coined a new term defining the neurodivergence? It would standardize the spectrum and might remove the negative connotations from previous terms. Those that discriminate and judge may not have the same power if it's a new term. If I, for one, describe my inattentive ADHD as being neurospicy, not quite scientific sounded, but it helps when I deal with those that have their own negative agenda towards our neurodivergent tribe. Do you mind if I just put something in just quickly? Because of Ivan, we really looked into it because we realized that the word neurodivergent doesn't actually exist in other languages. So I'm from Denmark originally. It doesn't exist in Danish. It doesn't exist in German, Spanish, French, Hindu. So in the British language or in the English language, we can use it. But because we are global, we have to think of a word that exists everywhere when all our papers and this were translated. So we went into using minority and majority, which also is not great. In some places, neuro-minority is not a good thing to say, but it exists in all languages. So that was kind of where we went. And we don't mean it as an offense to anyone when we call ourselves neuro-minorities. We mean it as a way where we can communicate across all languages. So over to you two, either one of you.
Yeah, absolutely. I think I've seen the term neurospicy that Eamon's mentioned coming up quite a bit, and I think a few people are really relating to that as an alternative way of describing their experiences. I think it's difficult because I think neurodivergence kind of was coined as a way to move away from diagnostic language, kind of that pathologizing. But then I think, because it is still something that represents a minority group within society, it does attract some of that discrimination and judgment from others, which I would be worried about whatever term we use would end up going down the same path as well. But I really strongly advocate for whatever term someone would prefer to use to describe their own differences and strengths and challenges should be used. Because I know, work with people who really hate the term neurodivergence and are very much like, just use my diagnostic label, or neurospicy, like I say, is one that's come up as well. And some absolute weird and wonderful ones that I can't just pull to mind at the moment, but kind of whatever helps, with your own sense of identity around it, I think is absolutely fabulous.
I completely agree. We have to respect whatever people identify with. Neurodistinct is another one I have heard as well. It's Becky.
Well, I was just going to say, the irony is never lost on me that autistic people are often perceived as overly categorical and rigid.
Yeah.
And yet we have these diagnostic criterias which are overly categorical and rigid and were not devised by the autistic community in terms of defining them. I quite like neurodivergence for me because I tick lots of neurodivergent boxes. And so I don't need to give someone my medical history by telling them. And also I don't cross the diagnostic threshold in every neurodivergence, but I've got features of some.
Yeah.
So I do think the historic terminology and the terminology that's defined by people on the outside observing is problematic. And I personally would very much like us to move to a world where we just talk in terms of what are people's neurotypes. And we assess people's neurotypes and help them identify their strengths far earlier, rather than worrying about a diagnostic label. But I completely agree with Helen that I think those that wish to other and put other people down in society, whatever terminology we use, we
will be
take those people that are motivated in that way.
I completely agree. And I mean, our sort of North Star is a world where we don't need the labels or the diagnostics, because we have changed to a culture where we as human beings are able to fully embrace differences, and we don't have to call them out all the time, whatever the differences might be, right?
We can hope.
So that's the next question: is to what extent does the sensory processing experience differ between ADHD and autism? This is probably quite a big question, but I don't know if you
really good question.
Brilliant question.
I love that question, mainly because again, this is an example where the diagnostic criteria is not seeming to match my experiences and many other clinicians as well who work within diagnostic services. So sensory processing isn't part of the ADHD diagnostic criteria, but it is absolutely a big part of many ADHDers' lived experiences.
Yeah.
And this is even for ADHDers who don't also kind of meet the criteria for being autistic as well. I would be interested kind of in reiterations of that diagnostic criteria, where they're going to bring that into kind of the criteria within the DSM-ICD. So I do notice differences, but again, this is absolutely anecdotal. I don't know the research on this, but as a general rule, I tend to see more sensitivity for autistic people and more kind of under sensitivity in ADHDers. But that's a very big sweeping generalization. There's lots of differences and nuances within that.
Thank you. And I think, I mean, what is 70% overlap between ADHD and autism in terms of, I'm both autistic and have ADHD, but first I was diagnosed autistic, and then I thought there's something else going on here, and then went to the second diagnosis as well, and that made sense. So maybe ADHDers that are highly sensitive to consider looking towards autism as well, self-diagnostic, whatever. And they said the same question for overwhelm. And with that kind of comes, can you have sensory processing disorder and not have autism?
Yes.
Be autistic.
Yes, you can. And you could be at the current time, you could be ADHD and have sensory processing disorder.
But it's still mentioned as a sensory processing in addition to ADHD then, yeah.
So when we do assessments with adults, if part of the driver, a really big part of the driver for them querying autism is because they're aware of their sensory processing needs, or their processing differences, the only diagnosis that has that within it is autism. So they come and say, I think I'm autistic. And actually, sometimes it's like, I think you're neurodivergent, but you're not going to cross the autism category, but you do have significant sensory processing needs. And you also have attentional difficulties and rapid thinking style. And so we end up going more down the ADHD route, but considering sensory processing within it. I will say, as flawed as I think the autism diagnostic criteria is, it's got nothing on how flawed the ADHD criteria is as it currently is defined.
Well, we need to be more involved with this ourselves so we can actually give that lived experience. There's questions are flooding in now. I'm sorry. I think we've run out of time, so we might have to defer some of them to the panel where you're in as well. But just very, very quickly, would unmasking whenever feels safe be a good strategy, especially considering burnout recovery?
Yes.
Yeah.
If a person feels safe to do so, then reduce the cognitive and emotional demand on yourself.
Yeah.
Masking.
We have to stop now to let the next speaker get in. But there's a number of other questions, and would you mind maybe have a looking at them and see if you see the Q&A or no? Otherwise, then you could type some answers so people.
Yeah, I don't know if it reached you, but I'm unable to stay for the Q&A, but I'm happy to look at the questions beforehand.
Thank you so much. Thank you very much. Both of you, delightful to have you here.
Thank you.
So for our next speaker, we're having Samuel Crutcher. I don't know if Samuel is here. There you are. Hi, Samuel. Sam is a London-based neurodiversity activist passionate about supporting healthy human development, strong communicating, and spaces for authenticity. The interdisciplinary interest infused social justice approaches with philosophical theories that empower individuals to reclaim their identities through person-centered frameworks and renewed conceptions of personhood. Thank you very much. I will pass over to you and leave the screen.
Thank you very much. Screen. Can you see this? Can someone confirm it? Sorry, can you hear me?
Yeah, we can see your slides.
Okay, cool. My internet connection. Thanks for inviting me. I was really glad to hear.
We can't hear you so well, Sam. Can you be closer to the microphone?
Let me try to take it.
Thank you so much.
Can you hear me?
I think I could hear you now, yes.
Is that better?
That's better. Thank you so much, Sam.
Okay, well, thanks for inviting me. I'm really glad that the previous talks were also touching on the somatic component of trauma and neurodivergence. And I'm going to be speaking about one specific aspect of how trauma plays up in the body, which is embodied misattunement. The idea that neurodivergence experience embodied trauma in neurotypical spaces, and specifically a chronic misunderstanding, the obstacles to misunderstanding, creating a trauma that's lodged in the bodies of neurodivergents by virtue of them being neurodivergent within a neurotypical society. And my talk will be rather exploratory. It will open up interesting questions and hopefully spark interesting ideas, contextualizing this work in terms of the history. I'm really glad to have heard about different policy providers in previous talks, and I will be speaking about somatic body-based trauma as a concept and understanding the philosophical and political dimensions of it. So Firstly, looking at embodied misattunement, how neurodivergents experience embodied trauma in neurotypical spaces. I'll be looking at the interrelationship between somatic theories and neurodivergence, the idea that by virtue of being neurodivergents, individuals will experience an accumulation of bodily tension from chronic misunderstanding in neurotypical environments. I'll be speaking about the mechanisms by which this arises, the consequences, and I will be speaking about the what of what is the trauma that neurodivergents face. And then to close, I'll be speaking about the how, the where, and the when, and ending with some provocations and some questions that I would love for everyone to consider. So we ask, what is trauma when viewed through the lens of neurodivergent body-mind? The idea that the mind and the body are not distinct, they're unified. I'll be looking at the history of what is trauma, which is focused on mind-centered psychological framings, that trauma is all in the mind. And actually, if we expand that out to also explore the body, it opens up an interesting debate and a greater opportunity of available policy prescriptions and framings and language. And I'll be looking at how neurodivergent trauma is structured by ongoing sensory, emotional, and relational disconnect in neurotypical society. The idea that trauma is about disconnection from other people, from the environments around us, and disconnection from ourselves. And given this, what policy prescriptions do we devise to address this, to reintegrate neurodivergent individuals back into society to make them more in touch with themselves? So who am I and why does this matter? Well, as Charlotte mentioned, I'm a neurodiversity activist. I'm a brain injury, so neurodivergent, very straight. I'm a maths researcher, so I study at the London Interdisciplinary School. So my internet connection is unstable. Just let me know if you're having trouble listening to me. I study at the London Interdisciplinary School, so I look at neurodivergence and how we treat neurodivergence and trauma through an interdisciplinary lens. I'm passionate about community, self-awareness, and the idea of safety in the body. In my undergraduate at the London School of Economics, I founded and inaugurated the first student-held Russell Group neurodivergent officer to create community on campus. And my own history with my traumatic brain injury, I looked at appreciated outdated trauma models that failed to capture who I was. And so I'm here to speak about new models that help empower neurodivergents to understand themselves and to help themselves. And I would love for anybody to get in contact with me via LinkedIn, my email, or Instagram. This workshop series looks at mapping the terrain of neurodivergent trauma, and I'm going to be looking at what is trauma for neurodivergence. Alternative conceptions of trauma grounded in embodied experience, grounded in body mind, looking away from trauma as being a psychological mind-based phenomena, something that happens embodied, lodged within the brain, within the nervous system, within our bodies as we experience the world. And implicit within all of this is a shift towards a biopsychosocial spiritual personhood. Previous speakers have spoken about biopsychosocial models, biopsychosocial spiritual models just simply expand new ways of looking at human beings and what we are capable of and how we experience the world. Again, opening up an interdisciplinary lens of who we are. And if we say that trauma is not just what happens to you or what happens inside of you in response to a world that misattunes to who you are, we come to realize that chronic misattunement creates a certain kind of embodied trauma that's lodged in the body, which affects our posture, which affects our confidence, which affects our perception, what we're able to say, what we're able to feel, what we're able to think. So looking at what is trauma, reclaiming through the body mind. With this, we're looking at the implicit idea that neurodivergent individuals are active body-based beings navigating life through their body and not through their minds. Through the mind, we were looking at pathologizing language, disempowering language, deficit-first language, defective, inculcating language. And as we look through body-mind perspectives and somatic dimension of trauma, we see an empowered role for human beings, for neurodivergence, and individuals coping with trauma. And this new language and these new framings permit an empowered approach to neurodiversity and trauma. So reframing trauma from the mind to the body mind, we're looking at traditional trauma models, frame trauma as a psychic wound or a neurosis of the mind. Newer models look at embodied dysregulation. Previous speakers have already spoken about nervous system dysregulation. There's also changes and damages to our perception, to our ability to interpersonally co-regulate with others. And from mind to the body mind, we're expanding up what human beings are actually, what they actually are and what they're capable of. So looking at a brief history of trauma. So the founding figure who first really defined our understanding of what trauma is and laid the foundations for how we speak about and think and what language we use to describe trauma was Freud in the 19th century psychiatry in the West. He spoke about psychic hysteria, the idea that trauma is a mind-based phenomena to do with repressed desires, often stemming from childhood, and subconscious battles of being torn between what we think and what we feel. And while we see that Freud was developing the foundations of the theoretical framework, the interesting development of how we conceptualize and treat trauma came from the wars. Firstly, the First World War, the Second World War, and then the Vietnam War. So firstly, in the First World War, in 1918, after the war, millions of soldiers came back presenting with a distinctive social problem for society. They were experiencing trauma en masse on a scale that no society had ever experienced before. And only really equipped with the language of Freud, the way that this was described, these World War I combat veterans, was combat fatigue, shell shock, and this was very much conducive to a moral framing of a moral deficit or moral weakness or a lack of willpower. And then the Second World War, millions of combat veterans returned from the Second World War. And again, there hasn't been much development in how we speak about trauma, and it was framed in the same pathologizing way. The interesting thing comes with the Vietnam War in the 1960s, 1970s, as a time of societal revolutions, with increasing use of cinematography, of the media, of popularizing what the actual lived experience of Vietnam War veterans were and the rest of these social revolutions. This is where we start to see Vietnam veterans coming back from the Vietnam War presenting with something which required a different kind of language, a different kind of approach to describe and diagnose and treat. And in 1980, finally, PTSD enters the Diagnostic and Statistical Manual. However, it's limited to cognitive and emotional symptoms. And with the various iterations of the DSM, PTSD is becoming more of an embodied condition according to the DSM, but still the somatic aspect of it is overlooked. And whilst I'm using here PTSD as a placeholder for all forms of trauma, actually other forms of trauma follow the same body-based somatic trace in the history that we're looking at here. And then in comes in a new paradigm of body-based trauma research, a new way of speaking about the issue, a new way of treating the issue. And a new paradigm is a fundamental upheaval in how we understand the phenomena, how we change the questions we ask and the meanings we draw from our field of study. The neurodiversity movement is one such paradigm shift of how we understand every single individual as having a specific neurodifference. And the body-based transformation is how we understand individuals and how we understand individual difference from a trauma lens. And as we reinterpret the familiar symptoms, the body-based lens, we generate new insight and generate new conclusions for diagnosing and healing. I'll briefly go through some of the figures here. Stephen Porges from the 1990s onwards. This all takes place within the empirical advancements. In the 1990s, we get unprecedented development of brain imaging techniques, of fMRIs, of new ways of studying what trauma is and how trauma plays out in the body. Whereas in the 19th century, trauma was only really explored through the therapist chair, which was only conducive to this mind-based lens. By the 1990s onwards, we actually had a magnifying glass into the mind, into the seat of the trauma, into the body. And so in the 1990s, the first individual to really lay the foundations of this nervous system perspective was Stephen Porges with polyvagal theory, the idea that trauma affects a sense of safety with different nervous system states. And trauma being the most chronically disactivated nervous system, the dorsal vagal shutdown state. Peter Levine developed a somatic experiencing therapy, the idea of trauma as a body-based phenomena as disconnection from the body's intuitive knowing, the trauma as the loss of the felt sense. Daniel Siegel's interpersonal neurobiology speaks about secure relationships and attuned communication, how that shapes the brain and the body, of the developing mind and individuals throughout adulthood. And then Bessel van der Kolk, with his seminal work, Body Keeps the Score, speaks about trauma stored in the body. Muscular tension, altered perception, and the disrupted self-regulation. And so there are various forms of body-based awareness, but two interesting facets I like to explore is interoception and proprioception. Interoception is awareness of internal bodily systems, for instance, awareness of our heartbeat, our hunger, and our breath. It's, do we understand ourselves to exist from the inside? And proprioception is understanding one's spatial awareness. It's understanding body position, balance, and movement. And the bodily awareness can be distorted in trauma. Through a body-based lens, we see that trauma actually plays out in the disrupted ability of an individual to feel themselves in space, to feel their own bodily awareness. And as previous speakers have discussed, being aware of how you actually feel and what you actually think, and if perception is arising from within your body, are you able to tap into those signals and speak to yourself? And then are you able to feel yourself in a spatial external environment? And that disconnection can really wreak havoc in social situations. As body awareness becomes distorted in trauma. And somatic healing requires awakening and reintegration of bodily states and bodily awareness, the regaining of an interoceptive and proprioceptive awareness. So as these forms of awareness becomes disrupted, it leads to dysregulation, anxiety, hypervigilance, disorientation, and disconnection. And the core of my presentation, I argue that misattunement is a form of chronic trauma for neurodivergence. Basically, society will experience some form of disconnection. The accumulation of body-based tension every single day from being misunderstood, the obstacles to misunderstanding in these spaces. And early trauma is where a lot of this chronic misattunement first takes place, with misattuned caregiving, the lack of co-regulation. This is building from John Bowlby's theory from the 1960s of attuned parenthood and parental styles. And then this chronic misattunement is then reinforced and replayed, and reproduced later through life as the nervous system encodes the felt sense of threat. It becomes the point where, by virtue of being neurodivergent in a neurotypical society, misattunement becomes chronic, and the nervous system learns to encode that the environment itself, the spatial environment, environmental space itself, is a source of threat. And we see that trauma is not just what happens to you, what happens inside your body over time. And looking further at embodied misattunement, trauma in context, we see that trauma is not just psychological, it's relational, it's social, it's embodied. As I highlighted before, we've come from a myopic understanding, mischaracterization of trauma as being a purely mind-based phenomenon that can be adequately treated from the therapist chair, to more something to do with movement. That's why we've seen the growth of movement-based therapies, of yoga therapies, of somatic experiencing therapies. The idea that trauma is relational, it's social, and it's embodied within our nervous systems. And as neurodivergents grew up in spaces, they learned to feel unsafe within the nervous system. The space itself becomes the source of the problem, and the chronic misattunement becomes a form of trauma. And the interesting implication of my presentation becomes the so what of all of this. So I've just described the what of what is the trauma, and actually the implications of the politics of misattunement. What does this indicate about the kind of society that we live in? As we come to realize that trauma is not actually a brain-based, a mind-based exclusive phenomena, but actually an embodied phenomena, this has implications. Since the 1990s, as we've learned to really study trauma and explore and appreciate it as being a body-based phenomena, we've come to see that actually the locus of these problems is within the body. It's relational, it's verifiable, it's less easily dismissible. When somebody has what Freud termed as psychic neurosis or psychic hysteria, it was easy to downplay that as somebody who was just going through their own individual problem that could easily be dismissed as not even existing. When it's embodied, you can actually start to say, you can actually identify it, point to it and say, this exists. And you can also, it elucidates the causal mechanisms, the mechanisms of what causes this trauma and the mechanics of how it plays out in the body. The language, it's less easy to pathologize and ignore this language. Things like gaslighting becomes a lot less easy when we start to think about actually this does exist, this embodied trauma does exist. It elucidates the social causes of trauma. My presentation is titled Embodied Misattunement, How Embodied Trauma Plays Out in Neurotypical Spaces. And we see that the neurotypical spaces themselves can be the social causes of trauma. And this means that society naturally becomes accountable for this relational harm. When we can elucidate the mechanistic causes of trauma affecting neurodivergence, and as we validate neurodivergence as being a valid demographic within society, as neurodifference exists and is equally valid for all individuals, and we start to validate that trauma exists for all individuals in embodied aspects, it naturally becomes less easy to dismiss either the trauma or neurodivergence or neurodivergent trauma in society. And society naturally becomes accountable for it. And so as I've spoken about the what of the what is trauma, and as I've spoken about the natural implications of what this means for society in terms of the politics of misattunement, I want to speak about the where, the when, and the how of trauma. The previous speakers actually spoke about the double empathy problem. And I'm going to be speaking about the dynamics at play here of the bidirectional miscommunication and misunderstanding. This kind of obstacles, misunderstanding between two people, the ability of an individual to articulate themselves, to understand their own needs, to express their own needs, to find the words for their own needs. Do they have the conceptual tools to describe themselves? Do they feel comfortable in speaking about themselves? And then whoever they're speaking to, whether it's on the left-hand side, whether it's their interlocutor, whether it's a space they're speaking to, an institution, institutional procedures, workplace norms, are they able to receive that expression? And this chronic misunderstanding coming from this blockage between a neurodivergent and whatever space or person they're trying to interface with, this will naturally lead to feelings of exclusion, of shame, and of self-doubt in neurodivergence. The growth of the neurodiversity movement since the 1990s, the growth of terminology such as neurodivergent, ways of speaking about it, I really hope to see words such as neurophobia that label discrimination and point it out and can identify and condemn it. These kinds of movements and languages really help empower neurodivergence. Looking at the feminist movement, for instance, with the hashtag #MeToo movement, we started seeing that office place banter was actually called out as sexual assault. And there were conceptual tools used to identify these problems. And there was a movement of people saying hashtag #MeToo, hashtag I experienced this too. And naming this and highlighting the shared struggle helped bind people together to help empower their ability to, on the right-hand side, speaking to the left-hand side, be able to marshal themselves as a legitimate community to make their needs spoken about, to express their needs as a part of a coalition of hashtag #MeToo fellow individuals unified in their struggle. And that naturally led to the left-hand side interlocutor, institution, space, or position of authority to be able to understand those needs and make those needs met. And as we think about what neurotypical spaces are we actually speaking about? As a neurodivergent individual, we are surrounded by spaces. We, throughout all phases of our life, our lifelong development, from early childhood, do we experience barriers to misunderstanding in our family life, in our private life, in our social lives, from misattuned caregiving and beyond? There's lots of research to explain how neurodivergent individuals struggle within that, and within education, from primary, secondary to tertiary education and beyond, and then workspaces. Just using myself as a case study, I was undiagnosed neurodivergent. So looking at this previous slide, I was neurodivergent who didn't even know they were neurodivergent, who didn't even have access to these terms. And I wasn't able to make any of these needs met or express them or even make them known to myself. So absolutely there was no recognition or validation of what I was going through, no support. And so looking at my struggles with education from the ages of 0 to 19, I was undiagnosed neurodivergent. I experienced a lot of invalidation. And moving into workspaces, it can be very difficult. All kinds of invalidation of neurodivergent ways of being, whether it's sensory in the workplace, whether it's workplace communication norms, whether it's appreciation to the sensitivity of how every individual works. And I'll be really interested to people who either reflect or speak about in their own Q&A to raise their own experiences of how they grew up, and their own educational experiences, and how they've been experienced in the workplace, whether their neurotypical space has actually reinforced or helped them feel more attuned to the environment. And so I want to penultimately say thanks for watching. I'm doing a master's project about this workshop. I'd be very interesting to hear further talks. If you enjoyed this talk, I want to meet like-minded individuals and organizations who are also interested in the concept of language, salience, in the idea of reforming, the idea of trauma being stored in the body, and collaborate if possible. I've put my LinkedIn, my email, my Instagram handle at the bottom. And to speak about provocations and next steps and Q&As, as we open up into the Q&A section, I would like us just to consider the following reflective prompts. Where do you see misattunement showing up in your own spaces, in your own life? What does safety mean for neurodivergent bodies in a neurotypical world? And as action-orientated thoughts, either put in the Q&A or just think in your own time, how can we design more attuned environments to mitigate chronic misunderstanding and embody misattunement? And what practices might bridge that bidirectional gap in understanding between neurotypical individuals and the neurotypical spaces that they navigate through? I would love to hear personal stories or people to contribute their own lived experiences. I feel that enriches the quality of the discussion. I'm aware that I finished a little bit early, so yeah, plenty of time to move on to the Q&A. Thank you, Charlotte. I hope my internet connection was okay there. I got some internet is unstable signs.
Yeah, there was a few blips, but we broadly heard everything you said. Thank you so much. And you had the slides to support it as well. Really, really good. I did really like the whole principle that we get traumatized by being in a world that's misattuned to us. I think that's certainly an experience I've had my entire life since I was very young, back in the 60s and the 70s, where nobody knew why I preferred to climb up in trees and be there on my own rather than being down on the ground. So much easier to understand now. And yes, when that's a chronic condition you're in, we all develop trauma. And I think personally, not being a scientist in any way, but I think we experience trauma from cradle to grave that just accumulates on a constant basis. It's not always what happens to you, it's also what doesn't happen to you, which from my perspective was a constant lack of inclusion. There was no inclusion in the same way as what other people found in family, in school, in friendship. There was no friendships effectively, or at work. So I think that's like because you question yourself so much. So we have a few questions in the Q&A I just want to address. So the first one is from Carla. I'm adopted adult with diagnosed ADHD. I would have come from trauma, but I see the difference between the two and how they interact with each other. I would not agree one causes the other, but they can come together and be treated separately. So I don't know if you have sort of some thoughts of that, because what I often have come across is a mix between minority neurodivergent traits and trauma symptoms, because obviously we can be and are neurodivergent and have trauma, and how do we sort of separate and look at them differently? So we make sure we don't say that our neurotype traits is trauma when in fact what they are is just traits, and then there's separate trauma.
Yeah, it's really important to distinguish that neurodiversity is not trauma. The entire point of the Institute of Neurodiversity, one of the values about celebrating neurodiversity, trying to resist pathologizing labels and terminology. I didn't mean to try and say that neurodiversity is a form of trauma. I was simply explaining that neurodivergents experience trauma in a particular way, and the bidirectional misunderstanding that comes from being neurodivergent exacerbates the trauma that exists. And because neurodivergents are less easy to navigate social spaces and to be understood in social spaces, that entrenches in a chronic form of misunderstanding. I absolutely agree that we have to move past pathologizing labels and celebrate neurodiversity as an intrinsic superpower. Not superpower, people always take issue with that. Is that just an individual difference?
Many things, right? Yeah.
We have to be tolerant for the ways in which individuals want to be able to self-diagnose and describe themselves and be inclusive to that.
Thank you, Sam. That's another question here from Lou. Sam, do you have any examples of how this approach has been applied successfully in therapy for neurodivergent people with trauma?
I was trying to look into some research for this as I was presenting my workshop, because thank you so much for the question. My presentation was trying to provoke interesting thoughts or discussions about where's trauma come from. It's been mind-based, to understanding what were the decisive influences that helps us translate that into the body, and how does that come about. So those individuals, all of them that I mentioned, Daniel Siegel, Peter Levine, Stephen Porges, and Bessel van der Kolk, in none of their books do they actually speak about neurodiversity, which I think is a real shame. Like him, who speaks about the racial aspects of trauma, which I find very inspiring because it speaks about the social aspects of trauma from a racial lens. But I really think that there's a need, which what I wanted to outline here, there's a need to really situate and center the discussion of embodied trauma in a neurodiversity lens. Can I think of specific research on this? I'm afraid I can't. I couldn't find any in my research, but I would love to be put in contact with any people in the Q&A who are doing this work, because I'm doing this research now. I aspire to be someone that's pushing this forward as neurodiversity specific somatic trauma.
Yeah, so thank you so much, Sam, because that is so needed. I've been to trauma events as well with the people you mentioned. And again, yeah, neurodiversity doesn't come to the table. And it's such a big subject with trauma. But of course, I would say so, being neurodivergent myself. But that's why we have this conference as well. And we will continue to look at neurodiversity and trauma so that we can discuss it between us properly. So that was an addition to that question, say, would you have any practical insights into how ordinary, non-academic neurodivergent people can work on their own trauma? Maybe some lived experience, if you have had any of that. Yeah,
that's a great question. I'm really happy that somebody asked that. Yeah, I've been going through a lot of trauma healing from various points in my life. You know, I was trying to say that PTSD was a placeholder for trauma in my workshop, but actually there are various forms of trauma. I've been diagnosed with both PTSD and CPTSD. I've had, we speak about small t, big T trauma, whether or not we buy into that terminology in a way. It's just various ways in which trauma is experienced. And I've had to really grapple with all of it, from being undiagnosed neurodivergent to diagnosed neurodivergent, and various facets of it in various spaces. Practical insight.
I would find that some of the same kind of methods that is used generally with trauma work also work for us, but it should be in a neuroaffirming sort of setup. So I think the same kind of trauma methods that therapists will learn broadly as a general one, I think they could apply the same to us. I have certainly worked with trauma in that way myself, but there is just an extra layer of that sort of neurodiversity informed way of being a bit sensitive to what is the trauma and what's the trait. Yeah.
I think, you know, neurodivergence inherently for neurodivergence is being positioned in contrast to neurotypicals, and there's an interesting debate about that, and we can discuss that, and that's fascinating. But basically, there's a struggle to communicate with people with a different brain type or neurotype, and so the reason why I'm so hopeful about body-based paradigm shifts is that it bypasses the need to discuss. You know, if you're in front of the trauma, the trauma, trying to speak what you're trauma about your experiences, but maybe you struggle to find the words, or there's a lack of conceptual tools to describe who you are and what you're going through, or the therapist or your interlocutor, whoever you're navigating with, struggles to understand you, or body-based, that bypasses the need for language, right? And I really am interested in creative aspects of trauma healing. Just last weekend, I was doing drawing type therapy, and music therapy is another one. And I do somatic experiencing therapy, which is Peter Levine's work, yoga therapy. So that would be my practical insight of how neurodivergent people can work on their own trauma, is find spaces that are neuro affirming, find therapists that advertise themselves as being neurodivergent or being specialized in neurodivergent experiences or processing your trauma, which I think is at the core of it. What I was saying in my presentation is it's not about the mind-based psychic neurosis, it's about the body-based bodily awareness of how we feel in the felt sense. And I would say I pursue my own trauma by reconnecting myself with my body, body-based trauma healing.
Thank you so much, Sam. There's another question that we would have time to. So this is from Rachel. Thanks, Sam. Enjoyed your sharing. Being neurodivergent, I especially like your insights on emotional misattunement. I've read up on allostatic overload, brackets, cumulative wear and tear on the body due to chronic stress, bracket end. And research has shown that parental misattunement does lead to chronic stress and shame, which factors into embodied trauma. Do you personally think parental misattunement affects neurodivergent individuals from childhood and more so than social societal misattunements? That's a big question.
It's really interesting. And the reason why I thought about biopsychosocial spiritual, I think the more appendages we add to the biopsychosocial, the more disciplines we incorporate into it, the more expansive our idea of what a human being is, the more empowering it is. And I've got a really good answer to this question. I don't really know if I can, I'll try my best. Our parental misattunement that neurodivergence disproportionately experience, it affects the way that we're able to navigate life consequently. And so as we go back and resolve, and let's not all just blame the parents here, as we go back and resolve our childhood disconnection and miscommunications, it strengthens our ability to navigate our present social situation. So I wouldn't distinguish those as being two distinct phenomena. The parental misattunement lays the groundwork that we then use to be able to navigate our society. But I don't think one is more important than the other. I think the rather than saying parental misattunement, I would just say the childhood background disconnection that we feel that affects our ability to navigate society. So to navigate society better, we've got to deal with the present. We have to retrospectively try and come to terms with the past. This is really interesting with therapy. There are different aspects of therapy. The idea that we've got to look backwards, retrospective, like Freud looking at our repressed desires. I'm not saying that there's no place for Freud or Jung or anything interesting like that. There's forward thinking, like Viktor Frankl's logotherapy. How do we find meaning going forwards? It's body based. How do we deal with the body in the present? So I would just stay clear of saying that black or white thinking, you know, and to close it, I would say the biopsychosocial spiritual model, the spiritual really being expansive and open in how we interpret that term opens up so many avenues for how we think about trauma, how we visualize trauma and how we treat trauma.
Yeah, thank you so much, Sam. Can we just throw one more at you, and then there's a small break for 5 minutes? This is the last one from Julie. She said, thank you, Sam. Hi, great seminar. I wonder if there's been any current research on premature babies that are placed in incubators and not connected to parents, more prominently the mother. I was premature in early 70s and was separated for over 2 months as a newborn, and would imagine this has hugely contributed to my somatic body trauma experience. Thank you again.
That's a really fascinating question. I'm not entirely sure because I'm a neurodiversity activist. I don't have much know-how on the research on that, but absolutely, I intuit. I suspect there's a lot of research on it. The importance of tactile touch. When the mother gives birth to the baby, it's very important that the baby is placed on the mother's breast, and having that actual physical connection with the mother is really, really important for the neurobiological development of the child, the connection. And so if a baby and a parent are actually separated physically and there's not the ability to touch or to feel or to see each other, absolutely that will create a stunted neurobiological development, I think. I mean, the research is fascinating. Did you know that looking into a baby's eyes, at a baby a few months old, looking into the eyes, every single second that a parent attunes with a baby's eye and actually sees them, and the baby feels literally visually seen, every single second, it will um, create millions of synaptic connections of healthy development. Simply a parent looking at a child and seeing them and making the child know that they are seen. This brings them to like Lacanian philosophy of the mirror stage of the baby starting to feel like they are being seen as an individual. Do they are they aware of themselves as an individual? It's really important that a young child, 2 months is earlier than this, but it's really important that a baby comes to feel seen, that their sensory experiences are seen and met and reflected and mirrored. And it sounds really difficult, the idea that if you were separated for over 2 months as a newborn, that's like a disconnection, which is very, it's not characteristic of natural human development, right?
Thank you so much. Thank you from that. We have to take a break now, but thank you so much for being here. Look forward to having you on the panel later. Thank you so much for your time and your insights.
Thank you.
Dr. Sarah O'Byrne. Sarah, I'm really sorry that we went over a bit. Are you?
That's no problem at all.
You are, okay.
I'm still here.
I'm probably not pronouncing your name.
No, Sarah, I'm delighted that you are Charlotte. Most people say Sarah, and it is Sarah. So thank you for that.
So you're you're going to talk about the integrated story, the assessment of children from trauma-sensitive, attachment-focused, and neurodivergent perspectives. So
yes.
Is that I just want to read your bio for you. Principal clinical psychologist and CEO of Treehouse Practice, a trauma-sensitive and attachment-focused service for young people and their families. Sarah has an interest in working therapeutically with young people who are care experienced and exploring the interplay between neurodivergence and developmental trauma. Over the last 20 years, Sarah has pursued additional training in the neurosequential model for therapeutics, along a 1-year training with Dr. Bruce Parry, attachment assessments from the DMM model with Dr. Patricia Crittenden. I'm not doing well here.
That's okay.
And video interaction guidance. Sarah and the team at Treehouse Practice have established 6 months training in trauma-sensitive practice for health and social care professionals, which I've heard people ask for a couple of times here. So this is a very good segue into your presentation. Over to you, Sarah.
Lovely, Charlotte. Can I just ask practically, do people want me to turn off the video or should I leave it on? What would be?
Leave it on would be great.
Leave myself on screen as well. Okay, great. So thanks for having me here today, everyone. And I'm really excited to talk to you, passionate about, and I think I can get the sense from other speakers here it's a shared passion. We're going to talk about assessment from an integrated perspective. So using different modalities, some of which may be familiar to people in terms of a more DSM or ICD-11 orientated approach, and others which may not be, but I'm going to talk to you about how to integrate theories and principles into your work and practice too. So as Charlotte explained, I'm a clinical psychologist by background. I have the real pleasure of working as part of an integrated multidisciplinary team. And within that service, we work with neurodivergent children and young people. And we also work with young people in the system who've experienced childhood trauma. And of course, young people who are both neurodivergent and in care and have experienced trauma and adversity in their lives. So our assessments are very much designed to think about the impact of trauma on development, to think about attachment or survival strategies, to think about neurodivergence, and to come up with a bespoke therapeutic care plan. People can read these if they're interested afterwards in terms of the values of our system. So we're going to focus initially on understanding the intersection between childhood trauma and neurodevelopmental profiles. And I'm sure this has been covered in some detail already today, so I won't dwell too much on it because I want us to really get into a case discussion, which I hope is going to help guide our thinking and our formulation around this topic. The first thing that I'd say is that sometimes there can be a fear of mentioning trauma. So for example, if we notice in terms of referral information coming in that there is a history of trauma or adversity, are we comfortable naming this directly with parents and carers? Sometimes there is a little bit of work to do within teams to ensure that that is named and brought into the discussion, and that we're validating and affirming those experiences as much as we're validating and affirming neurodivergence. That we're using very clear and direct language around trauma rather than skirting around the issue and maybe not discussing it. Because I'm sure we've all seen maybe assessments or reports where there is a history of trauma or adversity, but the report may be written solely with a neurodivergent perspective in mind. So that's just the first thing to say, that the people who have experienced trauma will know this, that will be their lived experience. And sometimes it can be a clinician fear around naming it that actually increases the elephant in the room, so to speak. We're aware, I'm sure, from other presenters too, around the idea of this double jeopardy that neurodivergent individuals are at increased vulnerability to trauma. And also, we know that young people in the care system and those who've experienced trauma are much more likely to be identified as neurodivergent. We also know that trauma is often untreated and unintegrated in a neurodivergent population. And that can be as much, if not equally more, about how our services are designed and set up in terms of inclusion and exclusion criteria. It can be really hard to get an integrated therapeutic experience. And I suppose we also know that there is that vulnerability to more negative life experiences as a result of some of those systemic barriers, difficulties accessing services for both neurodivergent and those who've experienced trauma populations too. I'm going to spend just a couple of minutes now. This is one of our modules, is solely around developmental trauma, but just I think it's important to distinguish what we mean when we use terminology around trauma. So most of the research papers will discuss the incident of PTSD in a childhood population, but that diagnostic category is overly narrow when it comes to those who've experienced cumulative impact of harm. So as we know, PTSD will capture experiences for those who've experienced isolated or more discrete incidents, but actually for many children and young people, there's a cumulative impact, which is colloquially known as developmental trauma. And that's much more about those repeated experiences of harm and adversity that happen within key relationships, and are associated with shifts in developmental trajectories. So I suppose that's the terminology that might come more from Bessel van der Kolk or Bruce Perry, who use this term, talking about those repeated experiences of harm within caregiving relationships. And I suppose what we know about that impact is that particularly disrupts our relational systems, adult-child relational systems. And I'd encourage you to look at the Child Trauma Academy database around the data sets that they have around this impact of adversity and relational health if people are interested in knowing more about this area. But I suppose one of the things that we're curious about when we enter into assessments is our default position a diagnosis? So what we know is that many children who've experienced developmental may be more trauma sensitive or attachment focused, perhaps out of a genuine lack of knowledge around this area, which is why afternoons like today are so crucial to our understanding. So there can be little sense of what might be needed for prevention and intervention. And what we also know is that the terminology or the words or the language that we use can shape reality and can shape interventions. So if we're not using or capturing the right story for the young person, that in turn will shape the reality of how their lived experience is understood, but also how interventions might follow from that. So we really, as I think the previous speaker pointed out, spend a lot of time and slow down the process to try and capture the story that makes most sense for the child or young person.
Sarah, so sorry to interrupt you.
No problem at all.
Put it in like full slide.
Oh, we're not in full slide. Apologies for that.
Don't ask me how to do it because
wonderful. Thank you. I wasn't even aware that I was doing that. So thank you, Charlotte. Yeah, perfect. So hopefully that's better for people. So if we have, I suppose, what we might term, that the incorrect pathway is identified, what that may do in turn is pathologize someone who has a lived experience of developmental trauma. So if there's a jump too quickly, for example, an ADHD is probably a prime example of this, where maybe a diagnosis has been applied without consideration of the integration of other factors. What that may do is unduly marginalize or pathologize another part of lived experience. So it's about being cautious and slowing down the process to get the story right. And it's not about, and I think as we're all pointing out here, it's not that we're not identifying co-occurring presentations, but it's the integration that's key. And sometimes that integration may not happen in as fluid or as comprehensive a way in our assessment processes. So, as I mentioned, we're going to spend a little bit of time talking about a particular case, and I hope that this is helpful to bring to light some of the integration issues that we're talking about here. So, I'll introduce you to Danny. So, Danny is 8. He was seen by a psychologist in his school at 7, and both autism and ADHD were suggested. He was referred to CAMS. The referral was not accepted, and there was a recommendation for an MDT, assessment of need type referral. Danny lives in a general foster placement with 2 other children who are not biologically related to him. The placement is at risk. His carers find his behaviour difficult to manage. He was removed from his mum's care at the age of 3, and he's had very limited contact since this time. Prior to this time, there were concerns about his mum's mental health. His dad has been in prison since Danny was 12 months of age. There is a positive family history of ADHD in relation to his dad, and his school would describe Danny as finding it hard to remain seated. He needs to make noise, and he benefits from adult support to redirect him to the task at hand. He has some possible learning difficulties. So just hold Danny in mind. We're going to return to him a little later on. He's going to be a bit of our guide about this integrated process that we're talking about here. So I'll just talk a little bit briefly. I won't delve into too much detail because I would suspect it's been covered already, just about that intersection piece between specifically trauma, autism, and ADHD. There are, of course, a whole range of other aspects of neurotypes that I won't go into here, but these are probably the most researched. So I suppose in terms of that impact of developmental trauma, really the areas that have been researched are around interpersonal competencies, so that sense of self and self-development, interpersonal, so I suppose that capacity to engage in relationships, establish trust and safety, regulatory, I suppose across sensory, emotional, physiological aspects of functioning, and capacity neurocognitively to engage in executive functions, cognitive abilities. So all of these being impacted differentially depending on the age and stage of occurrence of developmental trauma. And that's the key piece in terms of neurodevelopmental functioning. So you can already start to develop a bit of a sense that there are multiple areas of overlap and common ground between developmental trauma and different neurotypes. So some of these have been studied, I suppose, in terms of neglect in particular, resulting in developmental delays, particularly around language presentations, so studies of vocabulary in children who've experienced neglect. And I suppose we know that sometimes early communication differences will be that autism may be relevant for children too. So it's just being aware of that crossover. And equally, I suppose autistic children are overrepresented in a cohort of children who've experienced early trauma too. So there is certainly this piece of crossover between both aspects. I suppose sometimes, and we would certainly see this in treatment, sometimes an autism diagnosis has been given, as I mentioned, without consideration of trauma. And sometimes there's a need, unfortunately, then to perhaps revisit or expand out the lens a little bit to look at all aspects of functioning and to determine the right story. We also know that play and the seeking of, I suppose, repetition in play can be a feature both of developmental trauma and an autistic preference too, in terms of either making sense of and repeating patterns to repair, or perhaps that being a particular preference around play too. So we can certainly see both and pay attention to both. And as we've mentioned before, I suppose autistic children may display behaviors that are around sensory preferences, and equally sensory preferences may be true in developmental trauma too. So we just have a little visual depiction here. I won't spend too much time in it, but I suppose just to mention this in a little bit more of an expanded lens, that some of the behaviors that we may observe can have trauma, possible trauma explanations and possible autism explanations. And I think when it comes to that integration piece, we'll look at how we maybe explore both and are curious about both in our assessment process. So, for example, appearing withdrawn, detached may have a trauma or an autism underlying explanation, equally around sensory differences, communication, and play. And as I mentioned, there have been studies also around that interplay between ADHD and developmental trauma. So I suppose studies around maltreated children perform much poorer on assessments of executive functioning than children who've not been maltreated, even in emotionally neutral contexts. So even when foster care has maybe been established. Children who've experienced trauma perform poorer on cognitive assessments, tests of attention and concentration. And I suppose there may be overlapping presentations between both in terms of features of inattention. Risk-taking dysregulation around children who've experienced trauma does share similarities with maybe a more hyperactive, impulsive presentation in ADHD. So, for example, the child may engage in risk-taking or impulsive behavior because of that inability to self-soothe, or perhaps around hypervigilance, which can sometimes look like inattention. So it's about really being curious about what the function and what's driving the behavior for the child. There are also differences too, and I think that's important to point out when we're thinking about our differential presentation. So there may not be the same affective or interpersonal or somatic dysregulation in ADHD that we would see in terms of that impact of developmental trauma. So those core relational pieces that I spoke about may be part of that differential understanding too. And I suppose understanding maybe the difference between inattention and hypervigilance, or hyperactivity and risk taking to self-soothe. So it's important to think about those factors too. Perhaps around, although some may say around ADHD too, that self-worth or identity pieces can be expected, but there may be differences in those areas as well. And I suppose what we will sometimes see in a developmental trauma presentation is altering presentations depending on arousal levels that fluctuate. So, for example, a child that may present as hypervigilant and attentive to their surroundings and busy one moment, and then in a moment of freeze another. So there can be that more up and down type of presentation in relation to developmental trauma. So this is just similar to that we discussed around autism. So just being curious maybe about the possible explanations from different perspectives within both paradigms too. So returning to Danny, who we spoke about previously. So if we were looking at maybe designing an assessment piece for Danny from an integrated perspective, we would be exploring the interplay of developmental trauma, autism, ADHD, learning differences, and relational health, amongst other factors. So quite a comprehensive piece of work. And just to say, in terms of our process, we would spend about 2 to 3 months with a child and family. That might sound like a really long period of time. Obviously, families and children know that when they come to our service and contract with us, it becomes a very therapeutic piece of work in and of itself. So that by the end of the journey, there will be lots of rich learning about the child and family, a really shared formulation. We'll have walked and talked through the process all together along the way. So that really genuinely is the length of time it certainly takes us consider all of the interplay of factors. So with Danny, we would be slowing the process right down to ensure the right story and the right fit. We would be looking at maybe alongside an assessment piece, is there sufficient knowledge within the caregiving system around the impact of trauma? And are there opportunities for connection and, empathy and relationship building alongside an assessment piece? So if you like, intervening and building relationships alongside assessment can be important too, to see, do those have a shift in terms of that child's presentation or the understanding? Shifting perspective from one of blame to one of survival. So seeing behaviors as survival rather than something intrinsically that the child should be able to control. And we know that this is sadly a reality for many children who have behaviors that may disrupt the learning of themselves and their peers, that there can be inadvertently a blaming piece. We try and support a shift towards survival and understanding survival strategies and support parents and carers to do so. ADHD might certainly be a valid representation for him. Autism might certainly be a valid representation for him. But it is, even if it is identified, it's not going to be the full picture. And I think that's the key piece here. It is those integration of factors. So we'll return to him later on to look at the actual assessment process and what we would do with him. But that's to give you a bit of a backdrop. So how do we look at this interplay of factors practically? What do we do in an assessment process? So some of the considerations we would have would be around gathering information about the child's early developmental history, family strengths and needs, and parent care concerns. And that, I'm sure, would be standard in any assessment process. The review of the early history, maternity records, which are often particularly relevant around an FASD or a more drug-related presentation too. So really being gathering as much and as rich a history as we possibly can. We're always curious about the age and stage of trauma, so we would use our developmental timelines for that, looking at what periods in the child's risk history were risky, in inverted commas, in terms of exposure to trauma and adversity. And what we do know is that relational health is a much better predictor of outcomes than a history of adversity. So it is not the exposure to adversity that is key here. It's actually the history of relational health. And this comes from that hundreds of thousands of data set that I spoke about in terms of the Child Trauma Academy. So we're just as attentive to not just what happened in the child's life, but who was there to help them make sense of it, organize it, help them process their experiences or otherwise. And that being just as significant as the adversity. So when we do a timeline, we're looking at all of the wealth of experiences that have happened, but also the wealth of relational experiences along the way. We're working within a multidisciplinary team, and we do recognize that that is not a luxury that everyone has. But even if we don't have access to a multidisciplinary team, we're thinking across multiple perspectives. And we're building that developmental timeline that identifies maybe when behaviors first started to become relevant, or were they always a feature of the person's presentation. So a really rich kind of history taking and timeline gathering. We're trying to operate in as flexible a paradigm as we can initially. And that means suspending, the jumping maybe to, oh, it's definitely this or it's definitely that. We're being open and flexible in the process, and we're checking out with each other as a reflecting team if we're doing that. And I suppose calling each other out, because we all have our own diagnostic or paradigm biases, and that can lead to an overshadowing in the assessment process. So we're being curious and open as to what emerges. We're also monitoring how behaviours might change over the course of an assessment. So it's quite expected that young people who come into a service like ours may be nervous or fearful or a little bit closed down in the process or reluctant to engage. And that's okay. That's to be expected. But we're looking also in spending that length of time with the young person and their family, how that might shift in response to greater safety and trust and collaboration in the process. And that may change our thinking too. If it is unclear, and as I said, we're intervening along the way, so we're getting as rich a sense as we possibly can. We're not leaving people without, an aspect of neurodivergence identified, if there is something that needs to be identified, that is clearly identified in an assessment process. But sometimes, particularly if a child is very young, and particularly perhaps if there has been a recent change in caregiver, so children who have recently come into the care system or have recently transitioned in terms of placements, there may not be a clear emergent view that comes because of the lack of safety, because of instability in relationships. So that's the point where you'd be maybe doing 3 to 6 months of support and you'd be coming back around at it. So sometimes there can be this pressure to resolve things and tie things up neatly in a bow and come at a clear story, and that's not always the case. This work is tricky. And as I say, the story does shape the interventions that follow. So we would try and always identify the story, but if not, still remain working with the family until things perhaps have settled. And as I said, we would spend 2 to 3 months with a child and family in this process. And we know, we're very cognizant that that timeline might not fit with that of the referrers. So there is maybe an expectation that we might get this done quicker. So there's a constant negotiation around that and an explanation as to why this does take time. So just to mention some trauma-specific measures, I know Rachel had mentioned some previously. So the assessment checklist for children, which is a freely available measure, or for adolescents, trauma symptom checklist for young children, and the trauma symptom checklist for children. They tend to look at, the assessment checklist for children looks at more developmental trauma markers. The other two look at more PTSD, dissociation, sexual concerns markers, which are much more mapping onto a PTSD profile. These are not normed on a neurodivergent population, and that's important to say too. So we don't have good quantitative measures that are normed both in a population of children who are neurodivergent and have experienced trauma. So we're always having to be flexible and adapt our measures to fit. There isn't one paradigm that works well here. I won't go too much into Crittenden's model of attachment because that is literally another PhD. But what I will say is that this is the model that we have found most useful in terms of actually assessing attachment and looking at it in terms of what might be happening for the child. And it's not something that is routinely done. It's much more likely that perhaps the child might be diagnosed with an attachment disorder without understanding the survival strategies that underpin threat and danger and the reasons why relational strategies have arisen. So Crittenden's model recognizes that responses to threat are adaptive. So they're not maladaptive, they're self-protective, and they happen in the context of unsafe situations. And our attachment systems will change developmentally as we mature and develop. So, a baby, for instance, cannot use a socially promiscuous strategy. They simply have not got the brain maturation or development to do so. So what's available to us becomes greater as we mature in development in our brain. But it's not a static process. Our attachment system can change, particularly in response to change in context and environments and caregivers. So, again, when we're assessing this, it is always specific to that particular relationship and that particular context, rather than a static process. But the reason we're drawn to this model is because of the flexibility it offers in understanding strategies. So this is the wheel of all available attachment strategies, ranging from those that are deemed to be more secure and balanced, which would be our B strategies, our anxious avoidant, our A strategies, and our anxious ambivalent, or our C strategies. And if you think about our anxious avoidance strategies being those that involve a reliance on cognition or thinking, less so than on emotions, and our C strategies being those that are much more a reliance on feelings rather than cognition. So, for example, a child who might have overt displays of aggression to get their care needs met. So the child, for example, in a school context who needs to make noise or needs to do so in order to bring the adult close to them will be more likely to be assessed as having a C strategy. The child who maybe shuts down and complies and follows rules and is the good child, in inverted commas, would be more likely to be assessed as having an A-type strategy. None of these strategies are bad. None of these strategies are pathological in that sense. They have all arisen an adaptive response to a caregiving context, and they can all be assessed. But what I would say is that even if we don't have the specific training in those relational measures, we can still think relationally and we can still capture relational aspects in assessments. So there are particular assessments that we would use in Treehouse. So the child attachment and play assessment, the school age assessment of attachment, there's a whole range of them depending on the age and stage of the child's development. There are also attachment assessments that tap into the caregiving environment. So the meaning of the child interview is a lovely one that we'd use that looks about how the parent thinks about and conceptualizes the child. But even as I say, if we do not have these, we're looking at interaction in other ways. So we would use a lot of video recording, and I think video recording is a really useful clinical tool for a variety of reasons. It really allows us to slow things down. It really allows us to look at interaction in that minute kind of way, and it allows us to be curious from multiple perspectives. So that's something we would really encourage people to use. So what might Danny's assessment look like if we were to design that? We would certainly be curious about a school observation, using that as an opportunity to build rapport with his teachers as SNA. We would be doing our clinical interviews alongside our history taking. We'd be looking at his strengths and preferences. We'd be looking at his preferences in play through the play-based sessions with him. We'd be conducting that timeline of his developmental trajectories, his life experiences. We'd observe him in both structured and unstructured ways. So that really gives the opportunity to explore both play preferences and relational aspects of functioning too. So looking at him with a caregiver, not just with people that he's unfamiliar with too. We would also be using our trauma-specific screening tools. We would include an occupational therapy assessment to look at his sensory preferences and maybe to be thinking then too about activities that might assist with co-regulation. We may do an intellectual assessment, but we would also be considering bearing in mind the factors I outlined around how children perform on these measures. Is he safe and comfortable to do so? Might that be one of the later appointments, for instance? We would certainly be looking and assessing for ADHD and autism using our screening tools like our ADOS or ADIOR, but as I said, being cognizant that they are not specifically normed on a population of children who've experienced trauma, nor are the trauma-specific tools normed on a neurodivergent population either. And we would be assessing his relational or survival strategy and considering that in the mix too, and his current relationships too. So just finally then to look at that integration and what that might look like from those perspectives. So when we speak about differential diagnosis, we need to be cognizant of the lens through which we operate. And I think Charlotte mentioned this in terms of perhaps those who work in a solely trauma-focused service may see things through that lens, and equally those who work within a neurodivergent service may see things through that lens. We need to be really mindful of our own perspective, know our biases and our own windows of tolerance, and also consider what carries more weight. Arguably, I suppose that diagnostic model is much more in the everyday speak and in terms of our knowledge base around how parents and carers and schools speak about children, much more common to find stories around autism and ADHD than we do around developmental trauma. It doesn't necessarily mean one is better than the other, but we need to think about what knowledge base is there and where that pressure or influence is coming from. So we would speak about the critical aspect being the age and stage and the different stages, the multi-informant history taking. And also, it may not be possible to administer assessments in a standardized manner, and naming that and being flexible about that, looking at play and having those recordings of play and post-traumatic play versus perhaps a more autistic preference, and using our recordings to really slow that down and be curious about those themes. There are always multiple stories, and there are always multiple ways we could write and co-create stories. And I think that's the key piece. It is the co-creation, how we write and how we think about children matters and has an impact. And that has an impact in terms of views themselves. Children do adopt other people's words and definitions of themselves. So when we're writing reports, our language really does matter. So, for example, aggressive behavior is distress. Even that small reframe can have a huge impact in terms of how the child sees themselves and how people respond to those behaviors too. For example, if we are adopting diagnostic lens, what does that tell us? Does it mean that that's a state or a trait? Does it mean that there is fluidity and flexibility? So knowing that our attachment systems can change, knowing that recovery from trauma is possible within a sensitive, supportive environment which validates those experiences, we need to be cautious about how we're describing behaviors and how we're seeing things. Are we describing attachment as a disorder, for example, rather than a survival strategy? And I would argue that we, in particular around the attachment disorder terminology, we have to be really careful about describing it in that way. So just finally, just to mention, there is a difference between diagnosis and formulation. A formulation is much more around taking into account the context, much more about taking into account support systems, and much more likely to be co-created. So we also know that one autistic person is not the same as another autistic person. So stories should be unique and flexible and reflect that individual reality. We also know that, unfortunately, for many of our services, a diagnosis is a precondition to access supports. So that in itself requires a huge degree of advocacy and getting a little bit angry and cross about, all those factors. But if we arrive at a formulation, that really should be thought of as a roadmap, a story, a narrative that helps make those links between past and current presentation and is as unique and individual as the person themselves. So just finishing off with Danny. So our story about Danny, for example, would include the following elements. It would include consideration that Danny has experienced developmental trauma and that his caregiving environment was not predictable and was unstable, and that he had multiple caregivers. He is likely to have felt unsafe and he needed to develop survival strategies. Those included remaining vigilant to threat. He may be at risk of ADHD, certainly. There are indicators of regulation, differences, and there are known genetic and epigenetic risks in terms of his history too. So that remains part of his story. The possibility is that he has learning differences, which could also be leading to frustration and tendencies to express that frustration behaviourally. His relational health at current is poor, and we know that that is a much better predictor of future outcomes than adversity. So we need to work to improve his current relational health. His placement is at risk at the moment. The core challenges really at the moment are around regulation, and there's an expectation that is set too high for him that he should be able to manage those things independently, but of course he can't do so. He's missed all the early building blocks around the soothing and nurturing that comes with that territory. So if we continue to mismatch the expectations, we're setting them up for failure, not success. So the first step will be to bring awareness within the adult team, in his carers, in his school around that interplay between trauma and neurodivergence, and to promote increased safety, empathy, and curiosity. So working with the adults. So I'm conscious of our time, so please let me know if I need to skip any of this piece, Charlotte, or if I can keep going. I'm more than happy to do either.
Just give a bit because we need to go into the.
No problem. Well, look, I thought that's as good a place as any to finish off, and I'm sure this will be shared with people afterwards. So thank you so much for listening, and I'm happy to take any questions that arise.
Thank you so much for this. Was a very thorough presentation of all the variations that we see here. So there was one that I wanted to just bring, and then maybe the other ones, if you could look at them, maybe answer to them, or we can maybe bring them into the panel. The one that I found interesting was from Michelle. I'm wondering if you look into some of the positive traits that are often associated with ADHD and and autism, like creativity and helping differentiate between it, and I add into sort of pattern seeking, non-linear thinking as well.
Yeah, completely. And that's a really good point. Yeah, we absolutely do. And I suppose that is part of the unique story, isn't it? It's not just keeping that deficit focused model, it's looking at all of those aspects that really are strengths of particular neurotypes and bringing them into the story. And also looking at strengths in terms of, that's what I mean about that language shift, that we're not looking at things in terms of that deficit focused model. We're looking at, if it's from a trauma focused perspective, we're looking at survival as opposed to maladaptation. And that's really important distinction. If it's in terms of a neurotype, we're talking about preferences, we're talking about, I suppose, creativity or play associated with that, rather than naming things within that deficit focused. Yeah, it's a really good point, and thanks for pointing that out.
Thank you so much. Thank you so much. If you wouldn't mind hanging around, because we're going to bring everybody in for the panel now, and then start. And if you could maybe quickly look at a couple of other questions for you as well, if that's okay. So I think we will, yes. Hello, here we get the other panelists. Thank you. And thank you so much, all of you, for hanging around waiting for the panel. Shanta has to leave soon, so we were going to just pose a question to her first. And then we could go back to some of the other things, because there was quite a lot that came up during the presentations. So the question we've sort of put together for the whole panel, for all of you to comment on, is, what does each speaker see as the most effective policy change or action that could be taken at a population level that would be most impactful in positively shaping the future in this space? I know this is a really open, but that could be one thing. This is more important than other things to actually get to change, because we can then take that away and actually advocate for making some of that happen. So Shanta, if you would start, please.
Thank you so much, Charlotte. And again, I apologize that I will have to jump off early, but I appreciate the question. And given that all that's happening here in the United States around ACEs and trauma-informed care, I'd say we need to continue to, if you will, bridge the gap in terms of knowledge and continue to build awareness and acceptance, most importantly, of the ACEs science and trauma-informed care practices. I will also say at a population level, I'm not sure how it's going to play out with the current administration, but CDC was at the helm of doing a lot of surveillance work, both domestically in the US and internationally. Those efforts have halted. However, I am in contact with many of the folks who were engaged in that work outside of CDC, and there's no plan to stop. I mean, it's going to continue. So folks at UNICEF, there are some folks in Africa, sub-Saharan Africa, who are going to continue the violence against children surveys so that we can continue to document the burden of adversities, not just in developed nations, but in developing low middle income countries. So I see that work needed and continuing. So I'll stop there.
Excellent. Can I just get you the one extra one, and then I can let you go off? Sorry, because I know you have a family. So given the emerging understanding of the role of positive childhood experiences in offsetting ACEs, how could this knowledge most effectively be utilized to positively shape the future? This panel is like, so what? So what's next for the future?
I think that's a great question. Back in 2020, I worked with Nadine Burke-Harris when she was then the California Surgeon General. She put together like the first Surgeon General's report in the US on ACEs and a roadmap to resiliency. And in that, it's a hefty document, but in that document, it does it's a comprehensive review of the pathophysiology of ACEs and how ACEs and the toxic stress response disrupts early development, which can then lead to multiple health outcomes later in life. However, that document also looks at multiple decades of research on the positive factors for resiliency. And then Christine Bethel's work, the work out of Tufts on the HOPE framework, all of those and this is in the US. All of that, I think, is very relevant, and it is the trajectory forward. So we still need to understand ACEs are prevalent and the impact trauma has across population, even, neurodiversity, non-neurodiversity, all populations, and utilize the information on the pathophysiology, but then really hone in and really, I don't want to say capitalize, but kind of take the information we know about the pathophysiology, or not the pathophysiology, but the solutophysiology of resiliency factors, so we can integrate that to promote healing and recovery in those impacted. Does that make sense?
That does make sense. Thank you so much for that. I'll let you drop off now. Thank you very much for hanging on.
Thank you very much, everyone, and enjoy the rest of the talk. Sorry I can't stay on.
No worries. Thank you. Now I'll go back to the remaining panel. So I don't know, Helen, would you, I'll just repeat the question that way. So would you mind addressing the first question, and then afterwards Sarah and then Sam, if that's okay? So what does each speaker see as the most effective policy change/action that could be taken at a population level that would be most impactful in positively shaping the future in this space?
It's a very big question.
Big question.
And hard to kind of narrow it down, because I've got I have two main kind of thoughts going through, and I think the main one would potentially be kind of almost like mandating that a neurodiversity affirmative training across like healthcare, education, and employment, making sure that it's kind of regular, using up-to-date evidence-based understandings, because even now trainings are done that are based on very out-of-date evidence. So I think that would be really important. And kind of thinking about a lot of that, we touched on when I did my talk about the dismissal, invalidation, particularly when people have those like inconsistent profiles of strengths and challenges. It's like if people understood what that was about and what they were contributing to it, and that it happens for starters, that might be kind of really helpful. It also, I guess, would shift the burden from neurodivergent people's having to try and advocate for themselves, which when you're already depleted on resources is a huge ask. Yeah, and like, people being aware. And I think the other thing that kind of came to mind when I was thinking about it, sorry, I'm being really cheeky, like two things. Even though a lot of policies and stuff kind of already have this built in practice, it doesn't happen. And that is around any kind of assessments and supports being needs-based rather than label-based.
Yeah.
Because so often, a lot of people remain like having their autism unrecognized, or ADHD undiagnosed, whatever, because it's so difficult to get to the assessment stage. But things like for example, like the Equality Act in the UK, it should be needs-based, but so often it's used as a gatekeeping thing, or you need the diagnostic label to be able to then get the assessment of needs. So I think something that would shift us more in line with based on individual needs rather than individual labels.
I think that's a great idea. I would also love for neurodivergence to be a protected characteristic specifically mentioned in the UK Equality Act. Not all countries have the same, but whatever is representative of that in other countries, because that way we should be recognized also if self-identifying, right? And I think that's really important.
Yeah, absolutely.
Sarah, and sorry, Sam, you'll be last, and it gets diluted for every time someone says, well, you'll be first one then, but Sarah.
Yeah, I'm always really drawn to the structural influences on trauma. So, how our systems are set up and designed in and of themselves can be re-traumatizing for so many neurodivergent and individuals who've experienced trauma. There are so many hurdles and barriers to jump through just to get access to therapeutic services. And I suppose there does need to be a degree of flexibility on behalf of services to break rules, to advocate for greater access. The reality is a lot of neurodivergent children who've experienced developmental trauma find it incredibly hard to access any type of intervention services. And also, experience of developmental trauma are not recognised as a specific educational need. So there are so many children who are in a care system and have experienced horrendous experiences, and that is not recognised as a special educational need in the way that autism or other aspects of neurodivergence are. So the structural ways in which our systems are set up needs to be explored and examined. And I know that does involve a real rethinking of how we access supports, but I think it's needed. I think there's so many barriers that make things unduly and unnecessarily hard for people.
And you get diagnostic override, right? I heard so many people say that if they're diagnosed with autism, that everything that's wrong with them is autism. That's
Yes,
nothing else comes, even toothache.
exactly.
Literally, even toothache. I spoke to a mother in India. Took us 6 months to find a dentist that would take her son and look at his teeth. And he was banging his head against the wall, and people said that's his autism. But he needed 2 teeth extracted, 3 fillings, and a root canal, right? And he had had that pain for 6 months because he needed to be somewhat sedated to be able to do this, and the dentist wouldn't do that, and they just said no. Anyway, right. So we don't want that to happen. We need to have the treatments for the additional trauma or physical health or whatever it might be properly addressed. And I find that those
Absolutely.
most vulnerable in our community is not getting that, and that's very upsetting. Sam, over to you.
Thank you. So it was what would
Do you
be
want me to
the
repeat the question?
what would be the most effective policy action for the UK right now?
That's right, yeah.
I really appreciate everybody else's comments there. They're obviously coming from a very different background, speaking about other welfare realms. My experiences in education, when I was at LSE, London School of Economics, I did activism for establishing peer support there and developing platforms. And I definitely, I think this is probably generalizable to other welfare domains, but speaking specifically for education, I definitely think there needs to be a cultivating of a neurodivergent community, even like neurobiologically, feeling that we're part of a community, it improves individual longevity. But not just that, the greater awareness and the knowledge exchange that people who are access communities have, and accessing a neurodivergent community where people are sharing tips or experiences and validating that the awareness of self that comes from that and the self-esteem and the self-acceptance is really beautiful. I think there needs to be like greater platforms in educational institutions, greater peer support groups. I did research at LSE which spoke about how I found that proportionally speaking, the greater access to neurodivergent communities people had translated positively correlated with self-reported measures of well-being and study success, people's ability to engage with education there. And yeah, greater visibility, greater platforms. I think that could be anything from organizing what I did at LSE, like neurodivergent officer positions to greater talks, more talks in secondary schools, um, blogs. I think there should be like an organized podcasts in cities to improve the visibility of neurodivergence, get it out there, give people speak what neurodiversity actually means. Exactly like what in this wonderful workshop today, I think exactly that. It's like speaking it, sharing it. I really think the most effective policy action for education or many other domains is focusing on developing a neurodivergent community.
Yeah, thank you. I'm so happy to hear that because that's why we launched ION. Yes, so the institute literally was that for when I got diagnosed, my children got diagnosed, I thought, where do we go? Where do we turn? We're all older, right? We're all adults over 18, and there's literally nowhere to turn. So we started that in 21 to bring us together globally. We're over 30,000 people now come together, so, and in 47 different countries. So it seems to be needed, and you're spot on with that, Sam. I think that's absolutely, it's just how to do it when you're all volunteers and just want to bring lots of people together for reducing loneliness, you know, have a place that you belong. Well, where do you find friends? It's so hard because we're excluded. I certainly was excluded all my life, right?
I think a lot of people, including myself and most neurodivergent activists, they derive a sense of meaningful pleasure, like a deeper contentment of life, of contributing to this, sharing. Is yeah, I'm neurodivergent, you're neurodivergent too. Let's co-create something beautiful as a kind of community. So I think that's beautiful.
Thank you. Thank you so much for that, Sam. So another question, just so I'll start with you, Sam, now. So how can we best ensure that learnings encompass global voices and intersectional awareness to ensure the shaping of the future is a truly inclusive process? Because I think often we don't talk enough about the intersectionalities around, and I'm looking at this screen, and sorry, we're all very white and Western, but we're not all. We have different people from different regions coming on tomorrow as well. But it started very much as a white Western movement, and then how do we make sure, because that's only 20% of the global population, how to make sure we get LGBTQ plus in, that we get all the different ethnicities from the remaining 80% of the world, all of that, the different socioeconomic backgrounds, what have you. What can we do to best ensure that the learnings we have encompasses that global voice and intersectionalities?
Kind of a bit of a challenging question, I think, but a really interesting, really important one. I will probably go back to my point about community. If we say that community is really important part of developing neuro awareness, neuro acceptance, fortifying the neurodivergent community, the like self acceptance and self love, and all of that. I think then that opens up a really powerful opportunity to position non how do you call it, like other intersectional groups in positions of like leading the community, like trying to make sure that members of like people occupying certain platforms, or people speaking at certain events, or people writing certain articles, making sure there's because you can control that, right? A diversity of people contributing to leading the community across different intersectionalities. I think that would be a way in which we could control how we improve the intersectional representation in the neurodivergent community.
Perfect. Thank you so much, Sam. Helen, what do you think of this? And then Sarah after that.
Sorry, can I just make sure that I understood that it's about ensuring shaping. I'll try to write it down as you was asking it.
So I'll ask it again. Let me read it. How can we best ensure that learnings encompass global voices and intersectional awareness to ensure the shaping of the future is a truly inclusive process?
Okay. Well, I think one of the issues that has kind of played out quite, from what I've seen very often, is that a lot of time the intent is there for kind of taking into account like intersectional experiences and make things inclusive, but often it's a more how do I say it? I don't know how to word it properly, but it's expecting free labour from people from minority groups. It's like, oh, let's consult with experts by experience who have less resources than those of us with the power. Let's ask them to do it for free, just for the pleasure of being able to kind of. And it almost feels a bit box checking. So I feel like there needs to be a real redistribution in the decision making power around that. So it's about kind of co-creating rather than just consulting with people.
And I agree with that, and then acknowledging that we're not paying any of you for being here. You're using your own free time. So I really appreciate that. Yeah.
Yeah, no, absolutely. But I think it is often used without any kind of mindfulness around that happening. And I think looking into, I'm not an expert on policies by any stretch of the imagination, but it's about questioning who they're for and who's excluded from them.
Yes.
Kind of really bringing in that critical thinking to it. So it is about, it would need an overhaul, because like there's attempts have been made for inclusivity, but as we see time and time again, and as we see within kind of the services as well, there's a real underrepresentation of a lot of people from different minority groups, and we should really be like, okay, well, what are we doing? But not why aren't people more coming, but what are we doing to be excluding people? Because we are doing something, and that needs to shift.
To be addressed. And this is partly why I was thinking, well, if we can bring 1 million of us together around the world, because we're all neurodivergent at the Institute of Neurodiversity, then it's very hard to ignore us, right? And within that, we will have all those different intersectionalities and the global representation. We've done the World Autism Awareness Day for the last 3 years, and we have that representation across everything, and that's super important, I think, for the future.
So important, yeah.
I just want to say, I didn't write that question. So
I love a challenging question. It's great. It makes you think and reflect.
It's more, it seems to feed into what Ian is doing, but that wasn't the intention with it. So thank you so much. Sarah, thoughts on that?
Yeah, there's two things that come to mind, if that's okay. One is around the idea of power and privilege, and whose voices get privileged, and which ones are marginalized, and how from a greater position of privilege or authority, how we can amplify voices by being allies towards marginalized communities. And I do always think, as someone who works with care experienced young people, that they are a particularly marginalized group, particularly neurodivergent care experienced young people. They're underrepresented in our policy discussions and in our decision making. So I think we can amplify voices by being allies for marginalized communities if possible. And the other thing that comes to mind is around education, actually, very simply. In my training as a clinical psychologist, there was lots of training around neurotypes, but certainly not framed in that language, framed much more in deficit and disorder and diagnosis, and no training whatsoever in the course of a 3-year doctorate around trauma sensitive care. Now I'm qualified a long time at this point, but I'm not sure that that has shifted to the extent that we would like to see it. And I'm not sure that at a grassroots level, at an educational level, we're including enough training or any at all around trauma-sensitive approaches and around a neurodiversity affirmative approach. Way to go at a very basic level in planning how we train professionals and teachers and across the board, really. So there's lots that we can do to bring that to really improve how we approach this area.
And it did. I mean, some of the comments, what it shows that therapists really would like to understand everything better and to be able to distinguish between neurotype traits and trauma symptoms and look at some of those real differences. And we've been pushing, for example, in learning environments, could they have a minimum of 20% neurodivergent teachers or academics or whatever, to chances are that maybe we might be there already, but then it would be nice if people feel more comfortable to actually be open about that. But it doesn't feel safe yet, so we just have to keep advocating, and all of you are part of doing that, obviously, by ensuring that we try to teach people more of what things are. So I don't really want to go to an event and be told that I'm not autistic, I just have trauma symptoms, right? That's really so doesn't work for me in any shape or form, and it makes you feel sort of erased. Part of you feel erased, and I think that we have to be very, very sensitive to, and maybe try to inform the people who have those opinions, who are therapists. Trauma therapists should understand the trauma they add to other people when they say something like that, for example, right? So any other things you would like to bring to the table before we close this for the day? Any thoughts, anything you would like to comment on, completely randomly and openly? Sorry, that's a bit of a left-wing question. Sorry about that. It's just easier to answer questions, I know that. But it was just if something had touched you as we were going through and you were thinking, Okay, I mean, for example, I really thought that the piece around can we bring the strengths in, because actually that's where you can possibly see a real difference. Is there a way to test for the linear or non-linear thinking, for example, where the chances of non-linear thinking also being neurodivergent could be higher, and that could add into the which way do we go here, if you see what I mean, or pattern. I mean, I see patterns in everything. My brain does. I don't even. It just does it, and there is a way to just detect that and then see, okay, that's an interesting thing. Is that just a wiring that works in that way, and does that suggest that maybe I'm autistic, which obviously I am, but yeah. Sarah.
I think no, just touch on that, like thinking about I absolutely love that idea of, if we focus more on the strengths, we might be able to differentiate a little bit more. And I think that kind of doing neuroaffirmative assessments, where that is as much a part of the assessment as the challenges and the differences, really lends itself to kind of bringing that into it and using that as part of, as a substantial part of the evidence to come to a clinical judgment. I think when an assessment is done more in line with the medical model and focused on like the deficits, that's a real missed opportunity. There might be kind of tokenistic, or we need to put some strengths in here. But I think if the whole assessment is designed from a neuroaffirmative standpoint, then that just kind of comes into it more naturally.
It would look different then, right? In a way that would be helpful, I think, to the overall picture and understanding. Sarah, what do you feel?
Yeah, I was going to mention, I suppose, about how language does shape reality. So I suppose being really conscious from that position of maybe power or privilege, what words we write in our stories about individuals. So, for example, if we're describing someone as attention seeking, a reframe maybe connection seeking, so actually we're really conscious about what we say and how we say it. Or if we're describing someone as, inattentive, it might be that they have a preference for exploring all of their surroundings. So there's lots of ways that we can reframe things that are much more affirmative, first of all, but actually describing the behavior much more accurately too. So that we're not implying that there's a disorder or a deficit, but actually we're just simply describing what it is in a much more neutral and affirming stance, So I think we have to be careful, and professionals will often write reports that are not particularly sensitive to someone's lived experience in reality. So I think that's something we're always checking ourselves on. We do not always get it right, I will say that, but we have to constantly check and make sure that those words and that language is more helpful than harmful.
That's good input. Thank you so much. Do you have any thoughts, Sam? Or you're on mute?
I love that, by the way. Not attention seeking, but connection seeking. I've never thought of before. I thought it was really good. Could you please repeat the question, Charlotte? Is it just like
it's around the whole bringing our strengths into diagnostics as opposed to only our deficits? Because it seems that they're not looking really for the non-linear thinkers or the pattern seekers or the extra creative people that often is a part of dyslexia, ADHD, autism, those positive things that makes us sometimes, excel in certain areas. But they're never taken to the diagnostics. Maybe there could be a differentiating factor for seeing if someone is purely trauma, or someone is, for example, trauma and, say, autistic, ADHD, dyslexic.
I really believe in the power of interdisciplinarity, and I think everything that we do is being incorporate as many disciplines as possible in the way that we treat trauma, like using creative modalities, and the way that we identify trauma, identify neurodiversity, the way that we communicate these things. I think there's something really powerful, really underexplored, and it's going to happen soon. It's just like how do we start mobilizing it, but really trying to incorporate as interdisciplinary a perspective we have into all aspects of strengthening the neurodivergent community and the neurodivergent movement, and in all aspects, from the diagnosis to the communication to the popularizing neurodiversity.
Thank you. Thank you so much for that, Sam. Can I just ask another small one that's come in? Not so small, it's long, but I'll read it out because I find this one interesting. So, what would be your opinion on the societal expectations of neurodivergent women? I identified as a neurodivergent woman, mid-20s, living in Ireland, and as diagnosed last year with ADHD, suspected AUDHD. I have experienced immense rejection in certain public spaces, and most especially in the workplace, due to my neurodivergence, both when I was aware of my ADHD and when I wasn't, which proves a very invalidating experience of life. I believe for women, the stereotype view might be even more damaging. Hope this makes sense. I think it makes a lot of sense to some of us. Who would like to start commenting on this? Helen, can I jump on you? Sorry.
Yes, so it's a really important question. I think it's really interesting because I'm like thinking in my head, I'm like, okay, we're talking about when you know people who have been recognized as being neurodivergent, or is this kind of like pre-recognition? But I think generally
this was both sides of it, like the expectations of
I think
we are, even the diagnosis doesn't really change who we are,
well,
but it might change how we project ourselves.
Yeah, absolutely. And I think that generally a lot of the societal expectations are deeply harmful. A lot of that is tied to gender norms and a real lack of understanding of how neurodivergence kind of presents outside of that male-centric, kind of middle class white, anything else. And I think so that leads for women, there seems to be a larger pressure to conform, to mask, to kind of not cause a fuss. And like we do see masking, across different genders. It isn't just a phenomenon that is experienced by those, assigned female at birth, but I think it's the pressure to do that is much more on women and girls.
Yeah, and I think that's why we don't get diagnosed as much, because
we're massively under-recognized, misdiagnosed as well. There's a much higher rate of misdiagnosis.
I mean, I was so obvious as a child, like so obvious. It was everything with my child is unconcentrated. She lived in her own world. I lined up my dolls. Everything was there. But obviously back in the day, nobody really knew anything anyway. But you still want today, I had my daughter was in a girls' school, and there was definitely a number of girls that that looked like they could fit the picture, but nobody dealt with that. Like no, where in the boys' school, there was quite a lot of that being talked about, but not in the girls' school, and that's also a bit odd, right?
Yeah, absolutely. And I think kind of bringing it back to that other question that you asked as well around kind of the future being inclusive and taking into account intersectionality, that pressure on women. And when we think about the intersectional identities as well, so kind of women of colour, trans women, queer women, face even more erasure, exclusion, under diagnosis, less support. So yeah, I think society's expectations of women are generally quite harmful.
I agree to that. Sarah, thoughts on that? Is he frozen? No, you're there. Yeah.
Sorry, apologies for that. Yeah. I'm kind of drawn to your previous question, actually, Charlotte, around, I suppose systems can be either trauma inducing or trauma reducing, can't they, in terms of responses? And it's really hard as an individual to affect systemic change. In fact, it's nearly impossible. We do need a movement and a reliance on groups to affect systemic change and influence, and constantly being a thorn in system side, so to speak. So I think for me, it comes back to that policy discussion we had. Like if we have policies that say workplaces have to be neurodivergent and friendly and trauma sensitive, I mean, that becomes illegal or a policy requirement, doesn't it? So I think it comes back to a lot of that, because in fact, many environments are completely the opposite, and don't recognize the impact of those experiences in the workplace. So for me, it does come back to that real advocacy movement. And the longer I work in this space, the increasingly political I find myself becoming. So I think it's hard to do this work without getting drawn into those kind of big debates and discussions. And so I think we've a lot of yeah, sort of rattling systems and becoming irritants to do still to get there.
We don't always mind doing that though, right?
No, 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 we don't. No.
Sam, do you have any final thoughts on this? And I think then we'll wrap it up.
On the comment about societal expectations for women, I mean,
Yeah.
obviously I'm the only I do self-identify as a man on this panel, but I really do I mentioned #MeToo in my presentation, that the power of individuals come together and make something known and on their own self-constructed platform to push forwards an idea and change a policy agenda. And I wonder if there's any room for that, for some kind of #MeToo social media equivalent or something like that, just highlighting the experiences of this is what it means to be a female neurodivergent. Because yeah, women are underrepresented in the neurodiversity movement, and there needs to be some kind of movement within the movement, some kind of broader representation, and someone speaking about what it means to what the woman's lived experience is, and that could circulate on social media, or I don't know. I reckon I should hopefully come in the future soon.
I think we're working towards it, and it is definitely growing and growing, but it is a very young movement, really, right? I think the last 5-10 years it has really taken off, even though it started in the late 90s. But that's still very young. We can learn so much from the other minority movements, especially LGBTQ plus. I feel is definitely one we can learn masses from and collaborate with, because we have fairly big numbers in that as well, in that group. So we want to have all of this cross intersectionality collaboration on, because we want the same things. We just want equality or equity. That's all. We want to be able to be equal citizens in every way and be treated as that. That's not a big ask, right? That's just a human right. So I think on that note, I'll say thank you so much for all of you for being here and offering your views. Really, really appreciate that. I hope all our participants have enjoyed it as well. Thank you so much.